Welcome back, everyone, to the committee meeting. We're going to go ahead and get started. Thank you. So we had a very good conversation this morning, of course, with our elected officials and, of course, with Medicaid. The next section of today's meeting is going to be focusing more on crisis stabilization. In addition, speaking about more into the weeds of what different jurisdictions are following up with, and then hopefully by the end we can have more time talking about some of the policy recommendations. Just for our presenters, if you haven't noticed today, I think to me the most important thing is probably the dialogue and the conversation, not really the presentation, right? The presentation is obviously there for us to reference, and many legislators, as you guys are all presenting, we're scrolling through the slides, we're writing down questions, but I want to be focused more on the substance of what each of your jurisdictions are doing, or how your department is operating, because that is how we find the gaps and the themes between the state, local jurisdictions, and different entities. So I just want to make sure that we're all focused that it's okay to skip your slides. More of the substance on conversations is probably preferred. But let's go ahead and start with agenda item number 8, which is an overview of various funding sources dedicated to behavioral health and crisis intervention services, and a review of forensic mental health services provisions in Nevada. We have a few folks that are here from DPBH, from the statewide programming. So I'm going to go ahead and go to Carson City for our folks, and please begin when you're ready.
Thank you, Chair Dignate and members of the committee. It's a pleasure to be here with you this afternoon. My name is Shannon Bennett, and I serve as the Bureau Chief for the Bureau of Behavioral Health, Wellness, and Prevention within the Division of Public and Behavioral Health. I'm going to cover the crisis response system aspect of the presentation today. I'm also joined by Drew Cross, and I'll be passing it off to him here shortly. So a little bit about the agenda. We're going to talk about the crisis response system as a whole, a little bit about 988 and some of the data that we have to share with you today. The community health system, which you have spoken a lot about today, and I'll add into that a little bit, and then some plans for improving mental health in the state of Nevada. So the crisis response system is comprised of the technology around how our 911 systems and our 988 systems interoperate with each other. It provides someone to call, someone to respond, and somewhere to go in a crisis situation. It is focused on getting people into the most appropriate service and care, level of care for their situation at hand. It really requires a strong mental health system in order to get people into the care that they need and stop cycling through the system. We are required by NRS 433.704 to have a suicide and crisis lifeline. That is 988, and it goes into some of the detail there. Additionally, 433.706 explains more requirements and duties of the support center itself, and 433.708 requires us to collect fees, which I'll talk about more in a little bit. In addition, SB 237 that was added in or passed in 2023 legislative session added a requirement to support the provision of crisis stabilization centers at hospitals that hold those endorsements. A little bit about the calls that we receive in the 988 Nevada Suicide Prevention and Crisis Lifeline. We answer as many calls as we have capacity to answer in state. All the calls that we do not have the capacity to answer, or that fall in some of those certain population groups, as you see on the screen, fall back to a backup line. And there's a network of national backup call lines from across the country. The last three numbers, 156 calls to LGBTQ plus subnetwork, 109 to Spanish speaking, and the staggering 1,097 that were transferred to the VA, are calls that are transferred off the top by selecting a specific number after you call 988. I really wanted to highlight the 1,097 veterans that called from one of our area codes in the state of Nevada in the month of March. We are averaging, in March, we had a 67% in-state call answer rate. We've been hovering around that, around 70% or so for some time, as you'll see here. The red line indicates when 988 launched in July of 2022, so when it went from the 10-digit call number to just calling 988. And you can see our in-state call answer rates over that time. And it's important to note here also that SAMHSA, our federal partners, have set the goal that we should be answering 90% of our calls in-state. Commissioner Jones from Clark County talked about this a little bit earlier in the day. Crisis Now is the model that I spoke of at the beginning, where you have someone to call, someone to respond, and somewhere to go. And that model predicts, there's a calculator, they're rough estimates, it's just to give us an idea, it's not meant to be specific necessarily. But that calculator indicates that the Crisis Now model would cost $347 million to implement in the state of Nevada. That is compared with a staggering $722 million for an emergency department or inpatient scenario, as it's more set up now. And this was designed by a coalition of mental health partners from across the country that serve as experts in their field. It also talks about, on this slide, the number of mobile teams that would be needed to serve the approximate amount of episodes that we would see or that we see each year. This is on an annual basis. The number of crisis chairs that we would need, short-term and acute psychiatric inpatient beds to serve an annual amount of estimated episodes. Starting in June of 2023, we began collecting 988 fee revenue. We have collected thus far $11,665,091.02. We plan, or we anticipate, collecting $14,812,482.28 this state fiscal year. Our fee is at 35 cents in the state of Nevada. We have 8 other states across the country that have enacted legislation and are actually collecting fees. Those fees range from 12 to 60 cents. We were one of the first states to do this. And there are many other states that are in the process of doing it but haven't yet enacted it. You can do a state-by-state comparison with an interactive map at that link there if that is of interest to you. As I mentioned at the top of my presentation, and as many of the presenters before me today have spoken about, the mental health system as a whole has to be working appropriately for the crisis response system to work, because the idea is that after they have somewhere to go of that crisis stabilization center, or they're de-escalated before they get to that point, that we can refer them back into community mental health service organizations that would be able to care for them appropriately. But we have to have the capacity there to be able to take on those folks. This graph talks about earlier intervention and the better outcomes with earlier intervention for various mental health challenges. A little bit about the plan. So as I mentioned, we really can only see success with our crisis response system if we have a comprehensive and well resourced mental health system as a whole. So we need to find ways to be able to invest in that. We will continue the implementation of the crisis response system. We currently are in the evaluation stage of a request for proposals that opened up in the spring of 2024. We should be able to announce intent to fund or intent to contract within the next couple months, which is a really exciting time for us. We will be continuing to work with community partners to explore sustainable and realistic options for designated mobile crisis teams. We struggle with this a little bit in some of our conversations with community partners, because just like what you have heard much of before today, a designated mobile crisis team requires both a peer and a clinician to be 24/7 available on site at a crisis, and we don't have the workforce to support it, and providers are concerned about that. We have been able, as you've heard again today, been able to work with partners in Clark and Washoe counties to fund them for crisis stabilization centers using ARPA funding. And we also are continuing to support our partners in rural Nevada for options for crisis stabilization centers in rural Nevada as well. We do struggle with the lack of community infrastructure, as you've heard a lot about. A lot of our funding is tied to one diagnosis or another, so that has also been a challenge. And a lot of the funding, as you're going to see in the next slide or two, is one-time funding. It was ARPA, it was COVID supplement funding, things of that nature, and those things are coming to an end. And it is hard to uplift programs without sustainable funding. You guys have heard a lot about workforce today. I won't go into this a ton, but workforce is a challenge. There are 420 individuals in Nevada for every one mental health provider. That is a statistic I wanted to make sure that you heard. The committee asked for a list of all the funding that this bureau has. I listed it out here. I won't go into it line by line. This breaks it down one-time versus stable funding. So you can see about half of the funding. We have $181 million in the bureau right now. About half of it is stable, and we will continue to have that. That includes the addition of the 988 fees that I just talked about. But half of that is planned to end here in the next 2 years. On the graph on the right is our funding broken out by topic area. So substance use versus mental health funding, the far left, and then the second one to the right. I just wanted to point out that disparity there between substance use and mental health funding. And here's a list of our strategic plans. The Bureau of Behavioral Health, Wellness, and Prevention is also working on a comprehensive strategic plan to be done in early 2025. So we look forward to talking more about that as that finishes up. At this time, Chair Dignate, would you like to take questions now on this, or do you want me to pass it to Drew Cross to do forensic presentation?
Let's go through all the presentations first, and then we can come back for questions, please.
Thanks, Shannon. Good afternoon, Chair and Committee. Drew Cross, Statewide Forensic Director for the record. I'd like to discuss what we are covering today regarding forensic services in the state of Nevada. We will start with a brief explanation of the nature and scope of forensic services in the state, describe the challenges facing the system, discuss ARPA initiatives and other programs which will address the challenges, and plan for the future. Nevada is statutorily required to offer restoration treatment to individuals who have been found not competent to stand trial. For an individual to be competent, they must demonstrate the mental capacity to defend against any charges. They must be able to comprehend the judicial system, their charges, and be able to work with their attorney as defined in NRS 178-400. If a person is deemed by a judge to be incompetent to stand trial due to mental illness or deficiency, the person is then ordered by the court to receive restoration treatment. Restoration treatment is aimed at helping an individual acquire adjudicative functioning, the necessary ability to proceed with his or her case. After treatment, if an individual is deemed to be competent by a judge, he or she is returned to the detention center and the legal process resumes. The obligation to provide inpatient and outpatient restoration to individuals who are not competent to proceed is spelled out in NRS 178-425. Presently, 2 secure forensic facilities serve the entire state of Nevada, one in the north and one in the south. We also house a population of long-term clients who are unable to be restored and charged with select A and B felonies, as well as those found not guilty by reason of insanity. None of these services are covered by health insurance or federal funding. I wanted to express gratitude to Attorney General Ford for touching on the challenges facing forensic mental health in Nevada. Similar to other states, Nevada has experienced an increased demand for inpatient forensic services, which has steadily increased over the past 20 years. Nevada has been under 2 separate consent decrees during that time, due to not being able to admit individuals from the jail to a forensic unit in a timely manner. More recently, between 2012 and 2023, DPBH experienced a 148% increase in commitments, from 202 in 2012 to 502 in 2023, with 2022 being the most commitments Nevada has ever seen, topping nearly 600. Additionally, DPBH's long-term client population, this being persons committed for 10 plus years or found not guilty by reason of insanity, has increased 366% between 2013 and 2023, which has led to less available bed space for restoration individuals. The courts have fined DPBH due to the amount of time individuals have waited to be admitted to the inpatient forensic setting. You can see the fines per month and the total amount. The following initiatives will have a positive impact on those awaiting forensic inpatient services, which currently sits at 123 people. The first of those initiatives I would like to discuss is jail-based programming. Jail-based programming is a collaboration between Clark County, Washoe County, and DPBH. The goal of jail-based programming is to introduce treatment and programming earlier for individuals who exhibit mental health symptoms and whose competency to proceed has been brought into question. This occurs while an individual is in jail awaiting admission to an inpatient forensic facility. One goal of the program is the potential for improvement in adjudicative abilities, at which time an individual may be reevaluated, found competent, and removed from the wait list. In addition, this program will offer support for individuals returning to the detention center from inpatient restoration treatment to increase the likelihood of maintaining psychiatric stabilization and decreasing a possible repeat admission. Some clients will not be restored to competency and committed long-term to DPBH. This growing group of individuals committed for long-term have aged to the point of being infirm. These individuals receive more appropriate services and a skilled nursing level of care. Historically, funding for this has been a limiting factor. ARPA funds have been made available for qualified clients, and to date, DPBH has successfully placed 4 long-term forensic clients in skilled nursing facilities throughout the state and are continually assessing other individuals for possible placement. This allows those beds to be utilized for new admissions, reducing the number of clients awaiting forensic services. Workforce shortages impact services across the state, and the specialized training required for forensic work has only exacerbated the issue. Through ARPA funds, DPBH has been able to expand contracted services, bringing on several staff through this program, and will continue to do so with the available funding. Additional beds are being added to the Southern Nevada Adult Mental Health Services campus to expand the census and allow for additional admissions. Community collaboration has been identified nationwide as a proven method towards improving the lives of the chronically mentally ill and reducing reincarceration. We have done this through our jail liaison and diversion program. Our jail liaison is a trained clinician who will identify nonviolent offenders with low-level charges who are currently in jail awaiting inpatient forensic services. Once selected, these individuals are presented and discussed with the competency court, judge, district attorney, and public defender for potential diversion to other services that address their mental health issues. Some of these alternatives include assisted outpatient treatment, outpatient restoration, and civil mental health services. We are active in preventing the criminalization of mental health. Programs like diversion allow individuals with low-level charges and mental illness to be put into appropriate wraparound services in the least invasive setting in collaboration with our community partners. If approved by the court, the client will be placed on a legal hold and diverted to appropriate services to address their mental health challenges. DPBH has taken numerous steps to address the challenges facing forensic services in Nevada. One of those steps is a new forensic facility which is being designed for placement on the SNAMS campus in Clark County. This new facility will be able to serve all the commitments in Clark County and surrounding counties. All these initiatives will help to offer adequate treatment to individuals in need and in a timely manner, and will lead to an elimination of fines and decrease in delays in offering treatment, while also preserving the integrity of the judicial process. Thank you. And next we have Shannon presenting Fund for Resilient Nevada.
Thank you, Drew. Good afternoon, Chair, members of the committee. Thank you for the opportunity to present today. My name is Shannon Litz, and I serve as the Deputy Director of Programs for the Department of Health and Human Services. The Fund for Resilient Nevada was established in 2021, and it is specific to the state's portion of opioid recoveries, which are the funds awarded to the state from the Attorney General's opioid settlements. Through DHHS, the state of Nevada manages 43% of the awarded funds. Counties and local governments that are part of the One Nevada Agreement created individual needs assessments, and they receive funding directly. The opioid settlement funds are projected to be available for the next 20 years with allocations made each year. And the average amount of this to the state is going to be between 11 and 21 million, but it can be higher or lower, and there is some ongoing litigation. In the initial development of the program, the Fund for Resilient Nevada worked to establish the priorities of the funding as outlined by the Advisory Committee for Resilient Nevada. The Advisory Committee includes members that are appointed by the Attorney General, the Office of Minority Health and Equity, and the Director of the Department of Health and Human Services. And those recommendations were categorized as treatment, data, primary and secondary prevention, health equity, harm reduction, recovery supports, and system needs. And the outlined recommendations were used to inform the needs assessment and statewide plan. DHHS is following the principles outlined here on the allocation of funding, and some awards that are in process are related to workforce and support for children's behavioral health needs, as well as efforts related to gestational exposure to substances. And earlier this year, we did award some funding to organizations for youth programming to support awareness activities, community prevention, and treatment. Currently, we are focusing on prenatal care, early childhood, and adolescent services. The next few slides outline the identified gaps, and data and evidence-based practices were used in the development of the needs assessment to determine the gaps and recommendations, with the goal is to have funding into the communities to help save lives. Continuing on with some more of the gaps, one effort that we're supporting the needs of the state is through the Nevada Opioid Center of Excellence. And the center will develop and disseminate evidence-based and research-informed training and offer technical assistance to address opioid use, misuse, abuse, and overdose affecting Nevada communities. And that is housed with the UNR School of Public Health. And the next two slides outline some additional identified gaps before we move on to the statewide plan goals. And the 7 goals that have been identified and funding is allocated from the Fund for Resilient Nevada, it should all fit within one of these goals. And the program is working on a notice of funding opportunity that will be released in June that will include opportunities for funding for all of these goals. And that information will be posted on the website and shared with our partners. And then finally, this is an illustration that shows the funding breakdown as outlined in the One Nevada Agreement. And thank you for your time, and we're happy to take any questions.
Great, thank you so much. I'll start the first question. It's not going to come to a surprise what it is, but similar to everyone that we've had for all our presenters, you have the chance to fix the mental health system. What do you focus on first in terms of programming or initiatives? And you can't say funding because I think that's the unilateral theme, and that's a little bit of cheating. So maybe we can start there.
Thank you, Chair. This is Shannon Bennett for the record. We really need to work on building a comprehensive community mental health system that can feed into each other from multiple angles. Unfortunately, Chair, a lot of that does boil down to funding, but I do think that Administrator Weeks talked a lot about some of the different quality pieces and things of that nature that come along with some of those things. But I do think that that comprehensive community mental health system needs to be built out.
Drew Cross for the record. I think continuing to grow the relationships and partnerships that we have in place as Nevada comes to realize the sequential intercept model, continuing to meet with our community partners at the county court level to continue to find additional resources for our population that is very much in need.
Thank you for the question. Shannon Litz for the record. I think I'll echo answers that you've heard throughout the day, also adding a focus on a focused population of parents with children that are at high risk, and we're focusing a lot on prenatal care and screenings to help build stronger families.
Thank you. I greatly appreciate those responses. Shannon, I know that you were talking about the Fund for Resilient Nevada. The only request that I have is if you can provide, I don't know if you guys, I'm sure you have this already, but if there's like a spreadsheet or a table that we can see that tracks the opioid settlement dollars that we've received so far, what has been expended, how much we're receiving or expected to receive, like, I'm sure you have it all already, but if you could send that to us, I think that would be helpful for some of the legislators just to understand. So that's the only request that I would have. Any questions from any of the committee members? Let's go with Assemblyman Hibbets.
Thank you, Chair. I have two questions for Mr. Cross specifically about the forensic treatment programs. And I understand if you don't have the answers right now, I would ask that you give me the information or get the committee the information, though. And those two questions are, what is the current wait time at, let's say, a county detention center before they are transferred to the state for treatment? And then once they're at the state for treatment, how long is the average person there before they are deemed competent and returned to the local jurisdiction?
Drew Cross for the record. Thank you for the question. As far as the amount of time to get to the facility from the various parts of the counties, it averages around 6 weeks currently, and the amount of, or I should say the median length of stay within the forensic facility once admitted is 96 days.
Thank you very much, and I'm actually quite impressed that you had that at your fingertips.
Assemblywoman Brown-May.
Thank you, Chair. My question is also for Mr. Cross with regard to the new forensic facility identified on 33, slide number 33. Do we have an anticipated groundbreaking? Is it still at the Sam's location? I believe that's like Charleston area, West Charleston area in Las Vegas. Do you have additional information with regard to the planning and possible opening of that new forensic facility?
Drew Cross for the record. We are currently funded through the planning phase for the new facility, and I will send along any additional information.
Assemblywoman Gorlo.
Thank you, Chair. And I actually have 3 questions, one from each. Okay, great, thanks. The first one goes to the 988 Lifeline, and we're currently seeing or taking in-state calls around 67%. I was looking, it looks like we do have a little bit of a plan on how to get there with the 2 minimum call centers. Do we have a timeline on when that might be?
Thank you for the question. This is Shannon Bennett for the record. Yes, we do. We believe that we will be able to award the vendor a contract either in July or August. At that point, it will take them about 6 months to stand up the first call center. So we believe a Southern Nevada call center will be ready to start taking calls in early 2025. And then the second call center will follow 6 months after that. And those are rough estimates based on the request for information that we did last year. Once we get into actually negotiating with the selected vendor, we'll be able to provide a lot more finite detail.
Thank you very much. And then my next one goes to slide 22, the forensic service requirements. It was mentioned that those 3 services are not covered by health insurance or federal funding. I was just kind of curious why that was.
Drew Cross for the record. Yes, forensic services in the state are all funded through the general fund.
So a follow-up to that question then, is there a way that insurance companies could fund that, or we could get federal funding and kind of take the burden off of the state?
Cody Finney, for the record, Assemblywoman Gorlo, thank you so much. I'm the Administrator of Public and Behavioral Health. And just to add to what Mr. Cross is saying about why those services aren't funded by health insurance, is they're generally, the service is generally for the court. While the individual does receive treatment, the services are actually for the court. And so health insurance does not pay for that. And it is nationwide that you see that these services are generally not covered by health insurance or federal medical programs. I hope that's helpful.
It was very helpful. Thank you very much. And my last question, thank you very much for the indulgence. The workforce challenges. We hear this a lot in a variety of areas. And so I've kind of got the question of, do we have a timeline? But like if we did A, how many providers would that result in and be? And of course, there's the retirement and people leaving kind of in there. But I guess my concern is that for some of these providers, it takes like a decade for them to get all this training. So how can we actually get an adequate workforce development plan when, like I said, some of this is going to take 10 years. So do we have an idea of how that actually shapes up? A little bit more detail on that. Thank you, and then I'll quit asking questions.
Drew Cross for the record. I would say one of the key factors for recruitment in our workforce is collaboration with our institutions of higher learning. We have a forensic fellowship program. We employ residents throughout the state. We are recently starting an APRN connection with UNR. All of those will eventually pay dividends through a trained workforce prepared to help with forensic mental health in the state.
Thank you. Any other questions? Senator Nguyen.
Thank you. And this may also be a question for, I see Metro here in the room, so I may put them on the spot if they are not planning on covering this in the future. But I know that in December, as a part of IFC, we allocated some of those ARPA funds for that jail-based programming that, and that you had referenced. And I saw that in there, you said some of the goals were to allow for potential improvement in their abilities to bring them to competency so they could be taken off of those wait lists. Has there been a change in statute or agreement with DHHS as well as the jails to allow for that, I guess, that type of treatment that needs to take place in order to restore someone to competency? It's my understanding that that has to be done by the state, and that you can't do that in like a county jail-based setting. So I'm wondering if that is a typo or if there's been some sort of like partnership with the state to have those treatment professionals in the jail, or if you can give an update on that.
Drew Cross for the record. Great question. This would not be restoration. I think I mentioned in December, treatment exists outside of competency. Individuals will improve once treatment and structure are provided through this program, allowing the court to be notified and have the individual reevaluated. So this will not be the 178425 restoration component. This would be the 178415 pre-commitment evaluation. And this would be a second set of evaluations based on improvement of the individual.
Okay, I just wanted to clarify because I wasn't sure if it was restoring people to competency or just allowing for a secondary evaluation. So I appreciate the clarification. And if I don't believe any of these programs are up and running, are any of these programs yet up and running? I know that when we allocated that money through IFC, they had indicated in December of this year. So do you know if any of these programs are up and running right now?
Drew Cross for the record. Yes, there's been tremendous progress made in both Washoe and Clark County for the jail-based program. I believe the Board of County Commissioners for both Washoe and Clark had sole source funding approved for the two respective vendors. We are working closely with those providers as we develop the clinical setting and the type of programming that will be measured throughout the program. And we anticipate having additional updates throughout the summer.
I'm sorry, I'm just, so there will be a clinical setting within the jail. Are these individuals, how will they be referred into this programming in a clinical setting within the jail, pre-adjudication and post like being determined to be incompetent?
Drew Cross for the record. So individuals identified by the court in need of pre-commitment evaluations would be a portion of the group that would be in this unit. Additionally, individuals awaiting inpatient forensic services would be part of the milieu. And the third group will be individuals who have been found competent, who are returning to the jail. This program will allow them to be stabilized throughout the process. This should cut down on the amount of individuals who come repeatedly back to the forensic setting on the same charge because they decompensated or became non-compliant with medications.
Thank you. I was aware of the first and the third components when this was presented to IFC. I would like to see any additional resources or information that you have about that middle component where people are receiving treatment when they're in the in-between area. But that's all. Thank you.
Thank you. I'm still going through the process of trying to identify what questions I want to ask, but probably I can start with Drew. Drew, do you know, are there any gaps that we're seeing right now with the legal hold process that you're encountering? Are there things that we should be mindful of in terms of reforms to the L2K process? I've spoken to some providers and like there's some mental health providers that aren't legally authorized to process L2Ks because of their facility designation, but there's obviously room to revise or to look at it. So has that come up in some conversations that you've had, or is there a need to improve? Or I guess that would probably be my first question for you.
Drew Cross for the record, and thank you very much for this question. So the Legal 2000, or the various types of civil holds that are employed, have actually become sort of more at the forefront recently as we do diversion, as we attempt to get individuals into the least invasive setting. At times, a Legal 2000 from the jail to civil services to wraparound services is the ideal outcome for an individual. I wouldn't say it's a problem as much as the utilization of this process has been expanded to give additional resources and provide the appropriate setting for individuals.
So there hasn't been, I guess, do we need to have a discussion of enhancements that need to be made to the process in terms of like adding more providers that could proceed with it, or do you not see that as a problem right now?
Currently, we work primarily with clinicians at the jail who would be qualified to issue a Legal 2000, as well as the clinicians in the forensic setting. So for us, it's not a particular need.
Okay, thank you. This is more of the question from 988. So I'm looking at the 67% of the in-state call answer rate. So I'm trying to understand like the context. So if I, as an individual, call 988, it goes to the hotline, right? Is it fair to say that 67% of the calls are being answered and the rest are going to the national call line? Like, is that a fair assessment? And if so, is it because of a capacity issue where we don't have enough staffing to answer the 988 calls responsively, or is it more just it just depends if you call the national line versus calling in state? Like, I guess that's probably my first question.
Thank you, Chair, for the committee. Thank you, Chair, for the question. Shannon Bennett for the record. So, yes, someone answers all the calls. 67% of them are answered in state. It's based off of your area code. So right now, 775, 725, 702 calls are being routed to the Nevada Call Center. We work with our partner, Crisis Support Services of Nevada, to answer those calls. It is capacity that is keeping them at that 70-ish% in-state call answer rate. We do anticipate that to be remedied as we get this request for proposal awarded. Yeah.
So in talking about that, it sounds like it would be a staffing issue that needs to be occurring. But I guess my question is 988 as it currently stands, or as we will stand it up to be, are we ready to meet the needs of the community? I know that there's a question of, right, the LGBTQ plus calls that you're receiving, or folks that are speaking Spanish and so forth. So I guess my question is, are we prepared to serve the community needs as we're receiving these calls, or is there still more work to be done? And do you have an estimate of how much funds we'll need to get to that point, or at least an infrastructure request?
Shannon Bennett for the record. Thank you for the question. I believe with this contract that we are getting ready to award, the calls, that part of it will be answered, will be in good place infrastructure-wise for the calls, for the technology, to better understand the data and be able to develop programs around it. When we did the request for information, it it told us that it was going to cost between $5 and $11 million a year for this type of system, for the technology, for the people, for the staffing, the case management, the follow-up care, and all those types of things that the call center provides. Now, we are anticipated to bring in just under $15 million a year with the fee revenue, so I think we're going to have that part handled okay. Above and beyond that, the mobile crisis teams, the crisis stabilization build-outs, all those types of things, I won't know exactly our capacity to be able to work on some of those different programs until we get this contract awarded. But as you can tell, if the contract ends up being, $10 million a year or something like that, it doesn't leave a ton of revenue there to work with for those other programs. I hope that answers your question, Chairman.
Yeah. It does, and I think so. This is again in terms of like reoccurring themes. I think it's challenging, of course, for our state to stand up these systems of care, especially because right now we don't have the right processes in place. And so I guess my main concern is just making sure that it's not going to be perfect as we're starting this, but I want to make sure that we answer the question of what are the needs that we need to have before we walk into the next legislative session, so that we don't have to wait another 2 years to get the adequate funding or infrastructure. I think if we can figure that out now, whether it's making sure that every call that is received doesn't have to be diverted to a national hotline, I think we need to get to that point pretty soon of answering that request. The only final question that I had was on slide 22 that talks about the forensic service requirements. It says that DPBH is required to provide court-ordered inpatient and outpatient services, and it goes through different bullet points. And the last sentence is probably the one that triggered me the most in terms of trying to think through it. But these three services are not covered by health insurance or federal funding. Have you all seen other states require health insurance companies to mandate this as part of the coverage, or are there federal programmings or waivers, or is there some initiative to help at least supplant so that it's not all in the state to take this on? I guess that would probably be a question, just in terms of thinking innovatively.
Cody Finney, Administrator of the Division of Public and Behavioral Health, for the record. Thank you, Chair Dunyate, for the question. We've explored all the options we can come up with to look at funding sources, but it is very uncommon for health insurance to cover this particular slice of the services in the mental health system. Most states' direct services that states are providing are focused on this area.
Yeah, I think it's part of the systemic problem, which is throughout recent history, we've never seen mental health to the same equation as physical health, and so we're kind of playing this catch-up of reimbursement. I think oftentimes, right, there has to be a discussion of what is covered versus not covered, what is entitled, what does the government have to entrust for the population versus not, right? I think all of these are all conversations that we've had to have, and I was just curious to see if other states had explored this and if you had any discussions on how to improve the system. But I don't think I have any other questions. I'm sure we'll take some of them offline, but I appreciate you all. I don't know if you have any closing remarks or anything else that you wanted to mention. All right. We'll go ahead and close this agenda item, and I thank all of you for attending. Let's go to agenda item number 9, which is a presentation on crisis stabilization efforts and successes, challenges, and gaps in Nevada's crisis response teams. So for this presentation item, we do have several jurisdictions that are available and present. And so we have folks from Northern Nevada, Clark County, and the city of Las Vegas, and then, of course, our rural representatives. So let's start first with Northern Nevada, and we have the folks in Carson City, and of course, we have our former chair, Senator Julia Ratty, joining us today. So please begin when you're ready, and then once she's done, then we can go ahead and bring up Clark County.
Good afternoon, Chair Dunyate. Julia Ratty for the record. Thank you so much again for choosing to focus an entire meeting of the Interim Committee on behavioral health. I know that your needs are many, and so it's noted how much time and attention the committee is giving to this issue. So thank you very much. So in the invitation to speak, I just want to make sure that I'm clear what you're expecting. In the invitation to speak, there were sort of 3 questions that were posed to local government. One was crisis stabilization services. The other one was overall challenges in the behavioral health care system. And then the final one was gaps in behavioral health. Am I to understand that you would like me to focus just on the crisis response system portion of that to start?
No, you're correct with the 3, so please
So
proceed.
do all 3? Okay, great, thank you.
Yeah.
All right, well, again, thank you for the invitation, and these are the 3 topics that I hope to cover briefly today. I did hear your direction to not go over everything in the slide, so I'm going to do everything I can to respond to that direction. So first on crisis stabilization services, there were some questions earlier in the day about plans and collaboration across jurisdictions and how are we working together. So I do want to just pause on this slide for a little bit. In Washoe County, we have had a Washoe Crisis Response Coalition that was established in June of 2021. It has multiple levels, so there's a coordination and accountability team that has leadership from local government, law enforcement, hospitals, the managed care organizations, behavioral health providers, and folks who represent families and individuals with lived experience. They meet about quarterly, and that is the leadership of the region intended to help us remove barriers and keep things moving forward. There's also a provider accountability team, and in this setting, we have the direct crisis services providers, including Crisis Support Services of Nevada that currently runs 988, our MOST teams, which are law enforcement-based response teams, our CCBHCs that also have some mobile crisis response, Renowned Health, who you heard from today, and other key stakeholders. So these are the boots on the ground folks who will be implementing these crisis response systems. And then we have another group that is a children and youth crisis team collaboration that meets monthly. These are stakeholders that are focused specifically on the needs of youth and families in the crisis response system. And I do want to emphasize children are not just small adults. And so a crisis response for a child and their family often will be upwards of 2 months, as opposed to when we talk about adults, we tend to think of that first 24 hours. So just a distinction there. So there's an entire task group working on that. And then we have subgroups that are working on MOUs, training protocols, data collection, how to work with our familiar voices. And then we have participation from state representatives in each of those committees. So I want to do a significant shout out to Sarah Dearborn from Medicaid, Cody Finney from DPBH, Shannon Bennett from DPBH, and several of their team members who have been attending lots of these meetings since June of 2021. So I just paused there to demonstrate that there has been significant momentum and significant collaboration to work to stand up the crisis stabilization system. Folks have already covered most of this, so again, just reminding you that it's somewhere to call, someone to come to you, and somewhere to go. For us, we are anxiously awaiting the results of the RFP that Ms. Bennett just discussed and waiting to find out who our partner is going to be to work with on 988. For mobile crisis teams, we have some in the form of law enforcement-based teams, the CCBHCs, and we are waiting, I think earlier in the day, Ms. Weeks discussed that we're waiting from CMS to approval for the Medicaid rate for crisis response systems. Our concern here that I want to emphasize is this is the one part of the system that we really are struggling to find a sustainable long-term funding model that will make this work. Medicaid funding will be one piece of it, but if you're thinking about this as a public health model that needs to respond to anybody when a mobile crisis team is needed, that billing on a 15-minute increment for a service will not be sufficient to cover the entirety of the model. It will be helpful, but it won't be sufficient to cover the entirety of the model. So that is a real area of need if we are going to build out a full crisis response system. And the somewhere to go, we're very excited. You heard from Steve Schell earlier today that Renowned Health has been the recipient of several subawards from the state of ARPA funds to do the startup costs. We've also collaborated with the state for the location at Deanie Townsend, and we anticipate opening that crisis response center, or we're calling it our community care center, by the end of the calendar year. So in Washoe County, we'll have the 988 rollout we have 988 today, but we'll have the improvements that'll happen over the next year, the crisis care center opening within this year, and then work to be done on that middle piece of mobile crisis teams. I know that today is all about adults, but specifically on crisis stabilization services, wanted to spend just a little bit of time on children and families. So we do have mobile crisis teams in this space. They are operated by DCFS, by the state. They are wonderful, but they are not sufficient anywhere near to meet the need. So that is an area where we have been working collaboratively between Washoe County and DCFS to increase capacity. For children, you really don't want them to go to a community care center if you can avoid it in any meaningful way. And so to do that, you need strong in-home wraparound services to keep that child in their home, but also to keep them safe. And there is a significant need for increased in-home wraparound services to do so. And then for a small percentage of families that will need to go to a crisis stabilization or a respite center, we are excited to anticipate that with the West Hills building that was referred to earlier, the former West Hills facility, we are intending to, at least in the conceptual, we are intending to add crisis stabilization center and respite care for children, and that would open in late 2026. So if we can figure out mobile crisis teams for everyone, if we can figure out a bigger investment in in-home crisis wraparound services, we could be in a position by late 2026 to have a fully functional crisis response system in Washoe County. So moving on from the crisis system of care and just talking about challenges in the behavioral health system as a whole, these are the biggies, if you will. I've got a couple more slides that I won't go through in detail, but these are the big things that we're seeing in our community. So one is the volume of need is growing, simultaneous to declining available services. So we just saw during the pandemic that many of our key providers either reduced services or closed altogether. The West Hills facility being probably the most obvious example, but there were lots of places where folks were scaling back. As an example, just in our foster care system, we have about 50% of the foster care families that we had prior to the pandemic. So there's just some significant shrinking of available services. I'm just going to quickly say Medicaid rates and then move on. Fentanyl and the opioid epidemic certainly driving a lot of the challenges for our system of care. And then, as been mentioned several times today, our jail being our largest behavioral health facility in our community, and just really appreciative of the innovative work that is happening in that space, and grateful for the collaboration with folks like Drew Cross to really help us to work on some of those issues. And then finally, there's just overall gaps in the continuum of care that include a variety of levels of care. So for an individual patient who may not necessarily need acute inpatient care, but outpatient therapy is not sufficient, that missing middle of intensity leads to people either being over-serviced or under-serviced, if you will. And then that just creates dysfunction across the entire system. So filling in some of those gaps of level of care is important. Crisis response, I've mentioned before. Case management and targeted case management. So folks, unfortunately, our healthcare systems are just not always easy to navigate. And so, and unfortunately, many of the families and individuals who are experiencing mental health issues also need all other kinds of supportive services, and that often takes case management to get it done. Supportive housing is significant. There's been a reduction in community-based living arrangements that were one of the good options for having a person with serious mental illness have a place to stay. So supportive housing just continues to be a challenge. Not just that CBLAs are the entire answer, but supportive housing broadly. Workforce development you've already heard about, and then significant work around justice system diversion. So those are the ones that I'll highlight. I won't spend time going through these other gaps on any level of detail. I will just tell you that these were generated by department heads from across the county where mental health, behavioral health specifically is impacting their ability to be successful in their core mission. So whether that be the courts, whether that be law enforcement and the jails, whether that be juvenile justice, obviously our child welfare system, and our entire human services agency that also deals with adults and seniors. We have a crisis of senior isolation as an example for behavioral health. Also include our public guardian, who ends up working with a number of individuals who are no longer able to take care of themselves. So across the spectrum in the county, this issue of behavioral health challenges within our community is directly impacting our ability to be successful. And so if you spend any time on the next several slides, these were the issues that were generated by those department heads that they asked that I share with you, but I will not read them to you one by one. I did just want to take a minute to talk about some of the wonderful things that are happening in Washoe County. So this first slide is specifically Washoe County programs and what are happening. And so in the courts, there's some, I think you're familiar, of course, with specialty courts and familiar with courts having the role of facilitating access to services for many of the individuals who come through their systems. There's been some really innovative work done by in the Second Judicial District around competency court and really being able to accelerate the amount of time that individuals are in the system with competency questions. That has been super helpful. Also want to just flag here, give a little bit of credit to the City of Reno and their Reno Municipal Court, who's doing some really innovative programming called Community Court that takes place in our libraries and helps low-level offenders get, primarily the resource there is to deal with the citation or whatever has brought them into community court, but far more is about connecting them to services. They're doing community resource fairs and all kinds of things. So I want to give them a nod as well. Our public guardian, again, is more and more serving as the legal guardian to individuals who have co-occurring behavioral health and cognitive disorder. We have the Crossroads program that is a tiered supportive housing for men, women, and children. So we're in the supportive housing business ourselves. Just for staffing, I just wanted to let folks know that in the county, we now have 34 clinical positions where we have chosen to be the direct provider of behavioral health services among those many departments and divisions that I talked about earlier. So more and more, the county is finding the need to become the actual provider as the gaps in the community system of care that have been discussed earlier haven't been filled. We're just getting into the direct service. So just as an example, 8 clinicians at our homeless campus. Assisted outpatient treatment program is another wonderful program that goes through our civil court system where participants are ordered to comply with outpatient behavioral health treatment, and it has had a significant success level. Our alternative sentencing department, with some funding from DPPH, thanks to the state, has been connecting folks who are part of the alternative sentencing with behavioral health counselors and an innovative program with the Brain Health Institute. And then we purchased the West Hills facility, and you've heard a lot today about some of the jail-based programs that are happening, but we also have our MOST teams and our HOPE teams that are out on the street working with folks. And then finally, and this is my last slide, is again, back to the question of, is there a plan? Are folks collaborating? How is that working? Very specifically in terms of opioid settlement dollars, which I think is where that conversation started, we did do our needs assessment, we did do our plan, and we do have our RFP out, or our NOFO out for agencies to be able to apply and use those opioid settlement dollars. So definitely a good assessment process, a good planning process. So at the micro level, we are doing that. But I wanted to just let you know at the macro level, there is so much momentum right now around behavioral health and addressing behavioral health, and so many meaningful regional collaborations that require all of us to be successful. And we've talked so far in this committee about the state and the local jurisdictions and what they need to do, but I think there also needs to be recognition that our healthcare system is primarily a private system of care with for-profit and nonprofit providers, and for us to be successful, they also need to be at the table. And so in many of these instances, it's not just about government, but it's about the other players in the healthcare system being a part of the solution. So you, of course, are familiar with the Washoe County. There's a Children's Behavioral Health Consortium and the Regional Behavioral Health Policy Board. Those are both established in NRS and are meeting regularly and do some productive work. We have the Crisis Response Coalition that I spoke about earlier. I want to pause for a minute on the sequential intercept model. So again, want to give credit to the state for bringing in some national level speakers and really talking about sequential intercept model. If you are not familiar with that, that model is the idea of working with the justice-involved population, and at every point where we have contact with them in the justice system, having off-ramps. So if you think of it as a highway, if you will, with exits, and whether we're starting at the crisis stabilization level, where hopefully we divert to 988, they never call 911, they never have any contact with the justice system, or we talk about in law enforcement, so now you have had contact with law enforcement, but concepts within the intercept would be our law enforcement officers having significant CIT training, or our law enforcement officers having the most teams where they ride along with a behavioral health professional, or many other ideas along those lines. Then once you get to jail, do you have the opportunity, if you do have a mental health issue, are you getting adequate treatment? Are you getting connected with insurance? Are we doing all the things within the jail setting that we can do? And then it goes, you know, each of the intercepts go past jail to now you're in the courts, now you're in, you've been adjudicated, now you're out of the courts. And in every step, in every intercept, what are we doing to make sure that there is an off-ramp that both A, addresses the mental health and behavioral health needs of that individual, but B, should also increase public safety, because if we are doing a good job of addressing their needs, they are hopefully then not reoffending and not ending up back in the system. So we have an entire sequential intercept model coalition led by Judges Walker and Liu, who are, and we are working collaboratively as a community across, to work across and identify the gaps in each of those intercepts to make sure that for our justice-involved individuals, we're doing the very best we can to address the behavioral health issues. Our county commission, as you heard earlier, has prioritized behavioral health as one of their key focus areas in the strategic plan. There's a separate group called the Children's Behavioral Health Collective Impact Project, led by a nonprofit partner, the Children's Cabinet, that is working specifically on children's and family issues. We have lots of collaborative efforts with the Washoe County School District, too many to actually list them out, so I will just say that the Washoe County School District is an excellent partner, and we're doing lots of work with them. And then finally, the West Hills building, which will require a public-private partnership to be successful. And finally, acronyms, just in case you don't know any of them, I'm sure you know them all. And then I'll pause here for questions and hope that I didn't read my slides too much for you, Chair.
Thank you so much, Senator Ratty. In the interest of time, let's go through all the presentations and then we can ask questions afterwards. If Clark County is ready? Okay. And feel free to start when you're ready.
Okay, good afternoon, Senator Donate, and thank you for having us. Joanna Jacob, Government Affairs Manager on behalf of Clark County. Just confirming, because I just put up you can see my PowerPoint. Okay, perfect. With me at the table today to participate in our presentation is Deputy County Manager Abby Frierson. And then I have with us from UMC, Bud Shaw, who is our Director of Post-Acute Care and is also kind of the lead for us in partnering on our crisis stabilization project that we will be presenting today. I also, we do have Metro here, and Captain Zafsa, who heads up our detention center. He will come up because we will give you an update, Chair and Senator Wynn, about our work on the pre-forensic services as part of our presentation. Let me see. I guess I'll start. Just when we were working on this presentation, it is a bit like peeling back an onion. And one thing I did want to mention, as we're looking at human services and the county's role, it's not just what we are seeing as gaps today, but trying to look at planning for our future. We think this is a significant thing that we are working on and thinking too in the county, that we are projected to grow in our Southern Nevada region from 2.3 million today to over 3 million people just in a short amount of time. So we have to think strategically about how do we continue to provide our human services and regional services that we provide. And we want to think about this collectively with the state, because this is where our population is and where the projected growth is. Southern Nevada is a very exciting place to be, but we think we need to think strategically, not only now, but also in the future. We see our role as Clark County has a statutory obligation to provide indigent care, and that is really for the aged, the infirm, the disabled. This is where we have focused a lot of our programming. And in the course of working on this presentation, as my colleague from Washoe County noted, I kind of want to list it, the really where we are intersecting with behavioral health needs in our community. It is through our Department of Social Service, through our public guardian and our public defender's office. We fund the Clark County Detention Center. we have our Clark County Office of Public Safety. That's our police that goes out into our county parks and partners with Metro, Clark County Fire. We also share the funding, 2/3 of the funding for Metro shared with the City of Las Vegas, and we fund the UMC of Southern Nevada. I'm going to hand it over to Deputy County Manager Frierson to kind of look at, this is how we were looking at our crisis and gaps and how Clark County is looking at the problem.
Good afternoon. Abby Frierson for the record. I think you've heard throughout today that this lack of a comprehensive mental health crisis system is leading toward more people going to the emergency room or to jail than necessary. As we look at that problem, I think you've heard this over and over again. We need someone to call, which is 988, someone to come to you, which is mobile crisis teams, somewhere to go, which is crisis stabilization. But I think what you haven't heard as much about is I think there's a fourth area that we really need to plan around, which is where do people go after the crisis stabilization center? Or where do people who are unhoused go to continue their care once they've been stabilized? So I think there is a fourth category that we also need to talk about when we talk about this issue. At Clark County, we have stood up mobile teams. I think you'll hear there are mobile teams in the county, there are mobile teams in the city. I'm sure every model is probably a little bit different, but at their core, you've got a law enforcement public safety response paired with a social work response. At the county, we have 3 teams, and each of those teams is doing something slightly different depending on the need in each of those areas. So, for instance, we have one team that pairs with Metro's homeless outreach team, and those social workers will give resources to the unhoused and will connect them into our navigation center and our non-congregate shelter, which Ms. Jacob will speak about later on in the presentation. We have a team that pairs with our hospital, UMC, that does a lot of discharge planning to make sure people are able to leave the hospital as quickly as possible, making sure they have plans that will assure their safety. And we have a team that's still in its infancy, still finding its way, that I think that pairs with our Clark County Detention Center, which is going to be focused around coordinating the medically assisted treatment in the facility, but also working on discharge planning and working on connecting our unhoused our folks with some of those resources that we have. Sorry, one more thing. Before I turn it over to Mr. Shull from UMC. For crisis stabilization, one thing I did want to make sure is clear. We do not think one crisis stabilization center is going to meet the entire need in Clark County. We believe we need 3 to 4. So that we're hopeful that with Clark County stepping out first, that other providers will step out in this space as well.
Thank you. For the record, Bud Shaw, Executive Director with UMC. We are really excited to be working on and developing the Crisis Stabilization Center located up near Nellis and Lake Mead up in the northeast part of the city. As was mentioned prior with Director Frierson and the county purchasing the building, it's currently a 24-bed inpatient psych facility that actually never opened. We've got it. We're going to be doing some renovations so that we're able to convert to a 3 living room, 10 lounge chair bed model. And the idea is that we're going to be doing the interventions with anybody that walks in the door or is otherwise arrives, whether they walk in, whether law enforcement brings them in, whether EMS brings the patient in. No matter how they come up, we're going to go ahead and we'll provide them that medical screening, make sure they're safe to be in the facility, and then we're going to be treating them there. The whole idea is that they'll be helping them, we'll be helping them to decompress, to become more stable from their crisis that they're experiencing at the moment. Those that might have severe intoxication but are still medically safe, we'll go ahead and treat them and again help them get more stable, and then either connect them with the needed outpatient services through intensive outpatient care, or if they do need to be housed overnight or go into an inpatient setting, we have the resources and the connections within the community to transfer those patients into an inpatient setting. The whole premise on this is that these are all outpatient services. We'll treat the patient, get them stable, and then move them on to appropriate levels of care, whether it's within the community or whether it's in an inpatient setting. We'll be doing a lot of coordination with Las Vegas Metro and all of the rest of the law enforcement agencies in the county in Southern Nevada. And again, making sure that we do the right thing for the patients. And the big premise here is that we're going to be taking patients, diverting them from the ED. Right now, within UMC, the first part of first quarter, we had over 470 patients who were discharged from the ED into other mental health facilities. They didn't need medical care. They showed up in the ED, and we managed them. Over 3,700 hours were spent in the ED in the first quarter with patients who did not require any medical care. It was all mental health. So we're really looking forward to driving that down, and I think that's good. And then the next slide is basically the timeline that we are working off of. We do expect, we've closed the RFP. We've led an RFP because UMC is not a mental health provider. We're a trauma center and acute care hospital, and we do have UNLV residents and a psych program in the hospital, but we're not a mental health provider. So we've led an RFP, and that just closed for a provider to come in and operate the mental health side of the Crisis Stabilization Center. We'll provide the licensure and the administrative oversight and support, but we're really excited. We've got some great respondents to the RFP. We're expecting to have that completed and a provider decided upon in June. We'll work through the renovations that we're going to be doing, and we do expect to open up for the final surveys in early December, and then taking patients either late December or in January. Thank you.
Okay, I'll take over here. You heard Commissioner Jones speak about this earlier, about the Navigation Center, and I know many of you may have heard the county present on some of our housing programs. I did want to mention this here. One of the pieces of the partnership between UMC and the county and our Navigation Center and the Crisis Stabilization Center, the hope is, I think, in that we are able to provide the housing navigation that comes with the case management supports that are going to help us successfully discharge the patients from the Crisis Stabilization Center. So we think ultimately the success of that model is really bringing people in, but more importantly, as Deputy County Manager Frierson noted, is like, where do people go if they need a longer term period of stabilization, and where can they be handed off and leave the Crisis Stabilization Center? Clark County, I have here just as a way of illustrating what we're working on, Chair Donate, because you asked us to kind of say what we're working on and where we are in this space. You'll see the blue, the boxes in blue we have 4 non-congregate shelter. Non-congregate means it's not like a mass shelter with bunk beds, but individual rooms. And I've put the people that we're serving in each of those models. We started these non-congregate shelters during COVID. So when we talk about using ARPA dollars, the county really did kind of look at this. If we were going to use one-time dollars, how to put something up, but more importantly, plan to sustain it. These are being sustained with county funds. So we began with CARES Act, we continued with ARPA, and then we're sustaining with county funds all of these models. The Roadway Inn serves our senior population. We have something we're calling Americana. That is a higher level of care, assisted living beds that are available in our community. In La Quinta Paradise, we started, I know we are going to talk about kids next meeting, but this La Quinta Paradise really began when we started looking at where we can prevent families coming into our child welfare setting. This is a facility for families, so where only the housing instability was causing the referral into child welfare system. So that is that facility. And then we began, our newest one is La Quinta Valley View, which is another master lease hotel, which is kind of our model here. This is really adults without children. We began this as another avenue for referral from our navigation center, which is at the top. I will tell you, one of the things that the county did was really start with this non-congregate shelter and then began the navigation center. That was a successful model, not beginning with the referral line, but beginning to where that person would be referred. So once we have that resource in place, then we can start managing the referrals into the system. The Navigation Center, for those who haven't seen it, I invite you to come on down. It's on East Fremont. It is a really a short-term facility, but it is for 30 days, and then we can successfully navigate into these longer-term stays. And we're seeing some tremendous results. I have down here also some of the things that we're beginning to work on, and coming up next, I think we will talk about this. We've heard a lot about kind of our aged out foster care. As they become 18 and age out of our system, they transfer into our social service system. They become adults. And so we are working on a facility for some of our transition age youth that might need some assistance. We're looking on a specific facility for behavioral health and substance abuse for people who might need stabilization in that space. And then the hard to place adults is really one of the gaps that we have that we're trying to fill. And that's really where you have a serious felony, or maybe you are a sex offender. I think very hard to place in our community, that it's very hard to find housing. It's very hard to find a place. And so we are trying to focus on that population next. I want to just note here, and this is data through the end of March from our navigation center. I won't read it all, but this kind of shows how many people, like where did they go after our navigation center here? And I will note here 172 people were able to transfer into our non-congregate shelter that I illustrated on the previous slide, and 79 went into longer-term housing. We linked to vouchers. More importantly, I didn't mention that the Navigation Center, we do have case management that comes into all of these things. So one of the things that our model is kind of bringing the services to where the people are, I think, to try and fill some of these gaps. We have case management and also telepsychology and psychiatry that starts at our navigation center, and then we can refer on through a warm handoff into our non-congregate shelter. And then I will tell you, this is kind of how many people that we've served through our non-congregate shelter. And I think totally we have served over 2,300 people, and these are longer term stays, I will note. And so this is a model that we began and that we are able to grow. And this just illustrates kind of the distribution of who we are serving and where. I want to transition, because this is another thing that the county has been working on, and I really would like to comment here on, and there's been a lot of talk about Medicaid rates and how to improve access in the community. One thing that Director Weeks noted was, how do we see if it works, right? And she said one of the things that she was tracking was utilization. If we are going to do a targeted rate increase, does it help with serving more? Does it help access? Does it help serve more people? We found that it does. Here, I will tell you, long-term care, the county funds long-term care. And long-term care, this is for non-Medicaid patients. This is for people who cannot be covered by Medicaid or have no other pay source. That is a county obligation. I don't know how many people, some of you sit on interim finance, but in the last legislative session, and this has been years in the making, there was a budget change where the UMC agreed not to accept any more DISH funding, and it allowed us to free up some more funding that we were able to, and our commitment was to invest in long-term care that would actually help support the hospital community as a whole. We expanded our rates, and I've kind of listed here. On the long-term care, we increased our rates in skilled nursing facility coverage and as well in the group homes. And we added a behaviorally complex care rate. This was actually we have seen a dramatic increase in the number of people that we can serve because of these rates, and we are tracking this. And I had said that this is really showing the premise that if we do a targeted rate increase that is meant to address a need, when we began thinking about this, we were seeing some real delays in our people that we were serving in this long-term care space and waiting for a bed. At one point, we had an individual who was waiting for 592 days in an acute care hospital because they could not find a placement. Once we created the behaviorally complex rate, the facility could accept that individual, and we moved him out of the hospital. When we created the medically complex rate, we had an individual who was waiting 317 days in an acute care hospital. With that medically complex rate, a provider could accept that patient. We moved them out of the acute care hospital. We increased the amount of clients in the skilled nursing facility. It doesn't sound like a lot, but we increased it from 39 people who we were serving to 66, 46 people in group homes to 83 people. That is a dramatic increase. That's a doubling in our caseload based on the increases that we did and the amount of people that we could serve. I do like to mention this too, because this is a little known county benefit of something that we do. These homemaker personal care services. This is for people who are at home who need in-home services, personal care. This is actually grocery shopping, case management, prescription drug refills, and things like this. We added a mileage stipend, and we were able to increase dramatically the amount of clients that we could serve. We are currently bringing on, we have 20 providers of these personal care services through our homemaker program, and just this morning I checked with social service, and they are trying to bring on 3 additional firms. So this is really the county's initiative, and I wanted to make sure that we mentioned this, and this is premised on if we can do targeted rate increases that meet a very significant need in our community, that it can work if you do the tracking to see if it benefits utilization. So we would support any initiatives that Medicaid is doing to track that, because I think that, and we'll continue to track this as we move forward. I know UMC, Bud has said he's very thankful on this as our director of post-acute care, because it has helped to clear some of the patients out of the UMC emergency room. But if you have anything to add.
Ms. Jacobs, if we can wrap up the presentations, that way we can go through all of them. I think we're going through a little bit longer, so.
Okay, really quick, I apologize. This is a lot to cover in 20 minutes in Southern Nevada, so I apologize, Senator Dunyate. I won't read the slide. This is our gap, the missing middle. I will let Mr. Shaw put in on some of the things that we had said we were going to say, some of the impacts from UMC. I do have one more slide for the forensic services, Chair Donate, after this, if there's questions.
And Chair, I'll make this really quick. This is Bud Shaw again with UMC. Basically, UMC, we see 63% of our emergency room patients are either Medicaid or unfunded patients. As I already mentioned, the 437, 3,700 hours of time in the ED. In our inpatient care, we've had roughly 83 patients that had no medical needs, and they were in our hospital for 806 days until we were able to find them other discharge options. There's currently, based on a telephone survey that we did, really scientific, on Friday, there are 23 substance abuse centers in Clark County, and there's 82 open beds of those. There's 11 mental health, behavioral health centers here. One had been closed. There's 852 beds total, with 154 beds that are open today. The challenge that we have isn't so much finding an open bed, but it's finding an open bed that will take the rate that is being paid for that particular patient. So it's as much of a funding issue as it is anything else, truly. It's not the lack of space, but it's lack of the willingness of the providers to be able to take a rate that is below their cost. And with that, and that's a lot faster, but I'm going to turn it over to Joanna. And
Yep, here I just want to put on the record, I do have Captain Zafsa here so we can go to questions, but I do want to just correct, I want to state this is, there was a question about our wait time from Assemblyman Hibbets, and this is our wait time here in Southern Nevada from detention center from just our last report. The current wait time in detention center averages over the last 12 months, 101 days of patients who are waiting to be transmitted to Lakes Crossing or to Stein. I also have the numbers in here. The state did testify about the increase in the number of commitments that they've received. So this is the last 12 months. The number of inmates committed to Lakes and Stein from Clark County Detention Center is 313. I think over the 500 that they said statewide, number of inmates committed to Ross and Neal, 258. I have a slide here next on our upcoming projects, but we can save for the questions, Chair Donate.
Sounds good. Let's continue the presentations. I want to make sure, like I said, I think the more important part of these presentations are the questions and answers in the conversation. So I want to make sure that we're on track of time. If the City of Las Vegas folks can come forward, that way we can rotate. And then we'll have our rural Nevada presenters as well right after. It's nice to welcome our former Assemblywoman back. Hello, and please proceed when you're ready.
Thank you, Chairman Donate. Just checking to see that you all can see that. Excellent. For the record, my name is Sabra Newby. I am a Deputy City Manager for the City of Las Vegas. Thank you so much for inviting us to be here today. As one of my former bosses said earlier today, Mayor Sheevy, oftentimes cities aren't included or aren't maybe considered as much in this space of mental health care. And yet we do see the manifestation of it in our everyday, whether it's responses from our first responders or our homeless courtyard or any other various impacts. So thank you for having us here. So I'd like to talk to you today about the Recuperative Care Center. Specifically, the city has a number of different accesses for our unhoused population, including the courtyard and our MORE teams and other aspects. But I really wanted to talk about the RCC because that's the undertaking, the effort that we have that we are now transforming to include mental health services and a crisis stabilization center. So the RCC really is for the unhoused population. When you and I go into the hospital, maybe we have surgery, we're recovering, we go home and we make our partner bring us chicken soup and we watch Netflix. But for the unhoused population, that's not the case. They return to the streets and it makes it much more difficult to really fully recover. And so that's the ethos and the idea in which the RCC was born. Shelter staff cannot address medical issues. Oftentimes, the individuals need to leave the shelter during the day. They can't get their wounds dressed, and so it really exacerbates their issues, and they often end up right back where they came from in the emergency room. So while the RCC is the only one of its kind in Nevada, medical respite care is actually a thing. It's there are 145 of them nationwide in 40 different states. The capacity does range, and who runs the medical respite care also ranges. Most are nonprofits, some are FQHCs, and there's also a mix of funding. 72% of them report sort of a braided funding that that support RCCs. So our RCC, our medical respite care, is 40 beds currently, 38 regular and 2 isolation. We have a medication storage room. We have an on-site lab. We have no predetermined length of stay. It's operated through a contract with Hope Christian Health Centers, and that is a FQHC. So that is the model that we follow. They provide 24/7 medical care, and we have dedicated medical transport for our patients to get to their follow-up appointments or other appointments they might have. And we have intensive case management services. So while our guests are with us, we're trying to find their birth certificates, their other forms of ID. We're trying to find them housing and overcome those barriers to housing. So from its beginning in August 2020 to December 2023, it's served over 850 patients. As you can see, the discharge length of stay is about 45 days. We're really proud that 52% of our patients leave into some sort of housing and get stabilized. You can see here, and I'm not going to go over it, but how many patients are referred from various sources, and then some of the conditions that they're referred for. And then in terms of discharge outcomes, you can see a little bit more detail here and where some of the folks go when they leave us. Now, one of the things that we didn't expect when we opened this was the level of hospice care that we would be providing. It's sad to say, but we didn't expect it, but we certainly do that now, and it certainly provides a little bit more dignity to people experiencing homelessness when they're transitioning out of this life. So our RCC expansion plans, this is where it gets really exciting. So we were awarded a $10 million ARPA grant from the state. And we also have $7 million of City of Las Vegas ARPA to expand the services to 76 beds from 40. And that would add the crisis stabilization unit to our facility and let us serve a type of patient that we currently can't serve, that may be both recovering from some sort of injury or illness or surgery and may have a higher level of mental health need. So our current plan, initially we were going to expand onto a piece of land adjacent, but that halted because there were too many things to get over on that property. So our current path is to relocate the patients to an empty building at the Salvation Army that we will be renovating. We'll demolish the current structure. It is a former Smart and Final. It was definitely not built to house people or to be a medical respite care. It was a Smart and Final. And we will be building a new structure then to suit the RCC component and then the CSU functions. We're out to bid right now on that project, and so we don't know the exact cost, but we think that we will probably have about a $5 million gap there because we think it might come in about $22 million. Shh, don't tell the contractors. And because this section was called Successes, Challenges, and Gaps, I want to go over those. Our successes, I think, are really finding this gap and really trying to fill it in a compassionate way for people who otherwise wouldn't have that ability. And then, of course, the hospice care we think is a success, a win there, or a W as my kids call it. Challenges, of course, this is uncharted territory for the City of Las Vegas. This isn't typically the kind of work that we would do. City of Las Vegas employees have 3 values that we name, and they're kind, committed, and smart. So while we normally wouldn't be into this kind of work, we are kind and we are committed and we are smart, and so we saw a gap and we're trying to fill it. Obviously, limitations, I already talked about that on the physical Smart and Final space. And then I didn't mention this earlier, but we know that some of our partners, we get a lot of our clients from our partners, Catholic Charities, other folks, the Courtyard, and because we get them from there, we know that those patients probably left a medical setting, went to a partner they were not, the partner wasn't able to care for them, and so they end up back with us at the RCC, and that's kind of a circuitous route for them, and a lot of things, a lot of paper loss, medical records, medical charge things can get lost in that process. And then gaps. I mentioned the $5 million, which we're still working on, and then our stable funding sources for ongoing operations. I have to give a huge shout out to Director Whitley and all of his team at DHHS. They've been working really hard with us to try and find a Medicaid way to get some funding. We're working on home health care at this point, but we would like to work further with them on a medical respite care inclusion in a Medicaid program. And with that, I think I was under 10 minutes. I really hope I was. And that's it.
Great, thank you so much. Let's go with the last presentation on this agenda, and then we can invite everyone back for Q&A. So the last folks that we have are rural Nevada presenters. We have Ms. Valerie Quape, hopefully Haskins, I hope I got that right, and Sherilyn Wood from the Northern Regional Behavioral Health Coordinator. So please begin when you're ready. And thank you so much for joining us.
For the record, Valerie Haskin, Rural Regional Behavioral Health Coordinator.
And Sherilyn Rohr Wood for the as Northern Region Behavioral Health Coordinator.
My apologies, I'm just trying to make sure that this is set up. Are you able to see the, okay, fantastic. So thank you so much, Chair Doñate and members of the committee for this opportunity to discuss some of the challenges and opportunities that we see regarding behavioral health systems in rural Nevada.
So just a little bit about the boards. You guys probably already know at this point in time what we do and who we represent, but just wanted to remind you of the five regions and how they're broken up. That our boards really are multidisciplinary boards, bringing people from all over, legislators, doctors, lawyers, county members, lived experience, really sit on our board and really advise us on what to do. Writing our scope of work, creating our strategic plans, things of that sort. And then we are blessed to get one BDR every year or every legislation session. So really excited to have these conversations with the committee to move forward with our BDR.
So what we had originally planned was a lot of detail about the challenges and different things, but as most of this has already been covered in previous presentations, we get to cut this down quite a bit. So I'm just going to briefly go over some of the challenges that are persistent across all regions of rural Nevada. So you've already heard about our dearth of behavioral health providers, so that is no mystery. But something I did want to hit was the physical distance to both emergency and non-emergency behavioral health care, which really affects issues related to transportation and also how people are able to get there in a timely manner. So for the most part, if someone is trying to access inpatient or crisis care, they are probably getting there from their home community in the back of a squad car, maybe an ambulance, or a likely care flight, which is not really a good use of resources and not appropriate. Also, while Sherilyn will speak to the availability of Fast and Most and other deflection programs, there are not deflection programs set up across all counties or jurisdictions in rural Nevada as of yet. So that does create some issues and some challenges when we're trying to serve our folks. While telebehavioral health is an option that is frequently brought forward as a solution for our gaps in services in rural Nevada, the lack of reliable and affordable internet connectivity is a huge issue. I had heard about this from my constituents that I serve out there for quite some time, and then I moved about 30 minutes outside of Carson, so not even that far out, and internet costs twice as much. There's one provider, and it frequently drops Zoom calls. So I'm seeing this firsthand as a major issue. Another thing that keeps coming up is a lack of mechanisms to support complex case management across parts of the behavioral health care system. And this is really not just complex case management, but also care for complex behavioral health challenges. So we're talking about people who have one or more mental illness challenges, or substance use issues, and or physical ailments, and or potentially may be involved in the criminal justice system, but may or may not be on charges or seeing charges at the moment. And so Sherilyn and I get frequent calls from our human services agencies, our hospitals, and other local stakeholders trying to figure out how to get these people into the care that they need so badly when a lot of our care is very specifically siloed with specific parameters that don't really apply to these individuals. Of course, the lack of access to crisis and inpatient care is not only a physical proximity issue, but also can be related to insurance payer availability. Many facilities that other than NAMS and SNAMS don't necessarily take Medicaid fee-for-service. And while this will be addressed when the Medicaid MCO for rural Nevadans is rolled out, there's still going to be some potential issues there.
So I'm going to speak to some of the assets in our rural region. And when I speak to them, I'm speaking pretty much across the rural and frontier area. We've been really lucky to start working and building deflection and diversion programs in the rural regions, such as FAST programs, MOST programs, which you've heard a lot about. We'll talk a little bit more about that, I'm sure. But really building evidence-based to fidelity deflection and diversion programs is really, really important for that success, for those to keep moving on. And so we were able to, as a region, have 6 counties come across the county lines and really work on developing a FAST handbook for the state of Nevada. So we had bigger counties, smaller counties come together and say, how do we make these programs to fidelity and evidence-based? And so for 5 years, we really came across county lines and developed a handbook. So we're really excited about how that's going to move forward. And that's really going to help some of our rural regions put together other FAST teams comparable to the region that they live in and the counties that they live in. Really working on behavioral health task force meetings and coalition meetings, coming together and bringing those providers to the table that are needed when we are building a successful statewide crisis stabilization is important. Without having collaboration, it's hard to move needles, right? And so I really am thankful that in the rural regions, we really do come across county lines to develop programs, initiate new innovative upstream programs. Oh, I'm in this one. Okay. So just some more opportunities, some policy opportunities that we kind of looked at. The excellent work done during the last legislative session focused on community health workers and peer recovery support specialists concerning reimbursement rates with Medicaid and the addition of extra added language recognizing community health workers in behavioral health settings really gave rise to these professions, and we're seeing a lot more people come to the table and want to do this work. So the goal moving forward is really to look at developing program collaboration with the Nevada Workforce Pipeline. I know Dr. Hunt's going to do a presentation to potentially establish a mechanism such as a career ladder for our peers. Where do they go when they become a certified peer? What does that look like? We have that already with the community health workers, where they have a couple of different levels. So really focusing in on that. We also need to look at changing state law to enable peers with prior convictions to work as state employees. So long as they're working within their peer recovery unit. Arkansas passed a bill that just did that, House Bill 1433, really looked at bringing more peers with lived experience to the table by looking at their record, and if that's that low level, to be able to employ them.
Sorry to interject. Can you send that to us as an exhibit?
Oh, sure.
A copy of it? Thank you.
Yeah. And so as we move to robust diversion programs and co-responder peer programs, the need for certified professions with lived experience is really a must. We can't build these programs without our peers and our community health workers, as well as it'll help alleviate the burden and burnout on our licensed professionals. Not that they do that level, they stay in their lane, but it really does help during those treatment times sometimes to have a peer, kind of like a sponsor, be available. We're looking at that pay parity, and that job qualification challenge is really a must to look at as we're moving forward with these types of programs. Another policy opportunity is we have a lot of nonprofits that come to the table in our state and bring innovative programs. NAMI Western Nevada is one that I'd like to speak to. They employ peers and community health workers. They operate 4 successful warm lines, one being the teen text line, one the adult warm line, Caring Contacts, and then the teen youth version of Caring Contacts. And these programs have really been instrumental in utilizing our peers. Moving forward, funding more of these in-reach programs where we reach out, we're reaching into our people that need these services is really, really important as we're moving forward.
So we're going to discuss some other, for the record, Valerie Haskin, Rural Regional Behavioral Health Coordinator, my apologies. We're going to discuss some other policy opportunities. So another would be to find a mechanism similar to ADSD's MDT mechanism, but something that could really address people with complex behavioral health concerns, such as we mentioned earlier. That's not something that will necessarily be completely fixed by the Medicaid MCO, and there's no way to really address it right now. We also, this is kind of an icky one, and I want to put this out as a trigger warning for anyone who may be listening regarding death scene and loss to suicide. But it has come to our attention that while there are mechanisms in place for scene remediation when someone dies because they are murdered or in a murder-suicide situation, this is not the case for death by suicide. And this burden is usually left to friends, family members, and property owners. As you can imagine, this is pretty awful. It is also very expensive, usually several $1,000s to bring a company in. And if you live in rural Nevada, the process can take several days to get a quote and then get the company out to do so. So that also causes some biohazard issues on top of just kind of the rest of the awfulness on here. So addressing this through policy and creating a funding stream and maybe a contract mechanism to ensure that this burden is not really falling to loved ones of the person who has died is a very important thing to consider, please, as well. Moving on to workforce development, the Rural Regional Behavioral Health Policy Board, which I serve, has focused its last 2 BDRs on this broad subject, which I'm sure you've heard a lot about already. But some of the things that may be considered moving forward is looking at the minimum training for law enforcement regarding behavioral health. And looking at taking some of the CIT and other trainings that are becoming very common and putting that in statute or something similar. But furthermore, looking at dispatch and also EMS, because there are currently no statutory requirements regarding behavioral health, and they also are in the first line of response to persons in crisis. It has been brought up in various conversations that looking at whether or not EMS or paramedics are allowable or should be allowed to place mental health crisis holds. To be fair, I have not had an opportunity to vet this with those professionals yet, so, but that is something that has been requested by our stakeholders. And of course, I would be remiss if I did not mention the interstate licensure compacts for behavioral health professionals. This essentially allows persons who are licensed within a state that is a part of this compact to practice within the other state with minimal time and paperwork. It's about as close to having a driver's license and crossing state lines as you can get. So with that being said, earlier this month, my board did vote to pursue interstate licensure compacts with its BDR this next legislative session. However, since that time, it has been brought to our attention that this committee and potentially its members may be interested in pursuing that as well. So if that happens to be the case, we will happily support the work on that one. And if not, we will be happy to bring that forward as well. Insurance, so we have the Nevada Psychological Association presented to my board noting that the changes that were made to NRS last year regarding payment parity for behavioral health providers requires a little bit more teeth. And then another issue would be that mandating that private insurance companies do allow people into their networks when they are in good standing, because currently I've been hearing from providers that they are trying to enter networks in HRSA shortage areas, and the insurance companies are saying that their networks are full, which is hard to believe. Data and reporting. As far as data is concerned, it is very difficult to get data that is apples to apples regarding mental health crisis holds, the disposition of those holds, where those people go as far as facilities, and then what happens when they leave inpatient. And in order to fully evaluate the different pieces of our crisis response system and what is working and what isn't, we do need to have that information. It's also outlined in NRS 433.4295 as something that the policy boards are supposed to be reporting on, but we don't have the data to report because it's not being collected at the levels of various hospitals and other facilities across the state. You've already heard a lot about overdose prevention.
All right, Sherilyn Wood for the record. Sorry, I haven't been saying that. I'll wrap up with a few more policy opportunities, and then we can open the floor for discussion. This first bullet point focuses on ensuring that residency is feasible in our rural and frontier clinics and hospitals. This comes with adequate financial support, such as more funding for loan repayment programs with continued support and increased funding for the Nevada Health Corps program focused on our regional frontier social service employees. If we want to build crisis stabilization centers and provide person-centered appropriate whole health care across the continuum in Nevada, we must start by helping develop a capable workforce. And then unaffordable and unattainable child care. It's a glaring problem across Nevada. At every county behavioral health task force or coalition meeting that I attend, I hear stories of wait times, cost concerning childcare. The results of this capacity and financial burden affect older siblings within these households at all, as well. Truancy rates come high. Kids have to stay home to watch their younger siblings because childcare is not available. So counteract two things by helping to move that needle, potentially get kids back to school and not staying home to watch their siblings. So I know Carson City has been implementing a program recently through Project Aware, and it really is making a difference because it takes a village. And then we've heard this kind of talked about, that regionalization of health, behavioral health authorities is, I think, really important. Moving to this regional structure will enable multiple counties or regions, if you like, to apply for funding. A lot of times within the 5 counties that I get to support and facilitate meetings and things like that, a lot of times they can't apply for funding because they don't meet the qualifications of that funding source. So if we're able to regionalize funding and maybe apply as a region and having oversight of what those programs look like that come from that funding definitely could be a possibility, and I think implement more viable programs and priorities. Like I stated, one of the regions have been coming together with the COSAP funding and really working on building the FAST program and the FAST book up. So with that, that's our contact. Hopefully we kept it under 10 minutes.
Thank you so much. Let's go ahead and invite all our presenters back. Maybe we can I know there's a lot of them, so maybe if there's one person that can be at the dais per entity, and then that way, if there's folks that need to come on board, we can exchange seats. All right. So we've had everyone present. We started off the day talking with our elected officials, of course. Now we have the different jurisdictions. I'm understanding there's law enforcement folks also in the room, so there's obviously multi-level folks representing different spaces throughout the state being reflected here. And so are there any questions from any of the committee members for any of these entities? Okay. Let's start with Senator Nguyen.
This is for the city of Las Vegas. You had talked about moving the location of the medical respite care center and kind of, it sounds like combining it with hospice care and this crisis stabilization center. Do you have any concerns about the crossover of those different, I guess, client bases that are in there, or is that something that you've contemplated? Is that something that's typical in other crisis stabilization centers? It just seems like a lot of different, I guess, clients in one potential Smart and Final.
Thank you. Thank you for the question. For the record, Sabra Newby. Yes, we have thought of that, and the plan is currently to, when we move the clients that we have now, it will just be our typical recuperative care center clients. The new building that will be built in place of the Smart and Final will be 2 stories, and so we will be separating the population from 1 story to the bottom story. So the idea would be the recuperative care center would be on the bottom story, and then the higher level of care, the CSU patients, would be on the upper story. Currently at the RCC, we do have the clients who are transitioning out of life, the hospital, hospice patients within that population. So we would continue keeping them in that population of the RCC on the bottom floor.
And this is kind of in line, and this one is for the county. I thought it was going to be all the moms in my carpool up at the table here at one point, if Ms. Frierson was up there. I guess my other question is, when it comes to what the Clark County is already working on, creating this crisis stabilization center, and I think it'll be probably the first here, hopefully, opening up, the first of many, I should say. Have you guys have the different jurisdictions kind of coordinated to see location, to see where the city is thinking about putting theirs? I think there might be other city jurisdictions that are also contemplating this. What kind of coordinated effort is there to I guess, catch as much of Clark County at least as we possibly can?
Joanna Jacob, for the record, on behalf of Clark County. I'll be honest with you. Commissioner Jones has had some conversations as we have been looking to stand up. It's been a long time. We've been talking about a crisis stabilization center in Southern Nevada. I think when we testified earlier, we know we can't be the only one to serve the whole community. So it's really just a matter of, I think, collaborating with this. We haven't had those conversations to date, because I think this conversation, as we were preparing for this presentation, when we were talking to the city, this is relatively, I guess, newer plan that has been developing based on their needs. So certainly open to that conversation, I think. And then the second thing is that we're hoping that as we stand up this first one, I think there was everybody kind of watching to see who was going to go first in Southern Nevada. And so we're hoping that as we can see that if we can successfully stand up these models, that then there will be other people that will step forward to talk about it across the valley. Of course, we're the regional service provider. So if there are needs that the cities have that they need to contact the county, when Commissioner Jones talked about the staff is coordinating, I would say that that's true. I am staff, but it's not necessarily always going through our elected boards. Our county social service does work with our city colleagues to try and coordinate where we can. So short story is no, we haven't had those conversations yet, but I think it's definitely an opportunity for us to do that as we start trying to plan on the timing of all of this and how we can help to serve the need.
And then if Sheriff, I can just follow up on that third topic. Thank you for those answers, both of you. My next question is probably for Clark County and probably Metro. I had asked previously about those jail-based programming, and I know that our representative from the state had indicated that he believed those were up and running, but I don't know if they are, and so I'm just wondering if I can get an update on that. I know that it's still pretty early, but I'm hopeful that you guys have gotten through this faster.
Yes, for the record, Captain Scott Zaza from LVMPD. Yeah, we've identified the vendor. We've started weekly meetings. We've identified the module that we're going to run this pre-restoration in. We're pending Board of County Commissioners approval for the vendor, which we expect to get shortly. And ideally, what we want to do is have the project up and running late June.
And then my other question with regards to that is, as a part of your screening, if someone comes in and they are having They're either brought in by a mobile response team, they are presenting at the Clark County Detention Center. What type of mental health or behavioral health screening do they currently undergo? And with the implementation of this new program, is there going to be additional types of screening that will help, I guess, identify people that, would benefit from this early detection and startment of treatment?
Yeah, for the record, Captain Scott Zabs again. We have a robust mental health system already in place at the jail with our clinicians and our Dr. Arabsky. We hit the ground running from the time they come in the facility. We identify those that are in mental crisis or need mental health services. This program is going to be separate from those. Once they're identified to go in the pre-restoration, that vendor is separate from the current, will be separate from the current vendor, and those two services, although they will work kind of hand in hand, but they're separate. And if that kind of explains it.
Thank you so much. Assemblywoman Brown-May.
Thank you, Chair. My first question is for Clark County. You talked about long hospital stays that have now been diverted as a result of negotiating of specialized rates for complex cases. Is that a pilot program? Do we have an ability to negotiate on a case-by-case basis in order to move people out of long-term stays? Have we started a new plan to be able to address the financial implication of a complex patient?
Joanna Jacob, for the record. I'm actually looking for my notes. It is a current program. It began January 2024 with the rate increases, and we really developed it in collaboration with some of our providers. And so in terms of negotiated rates, I think the way that the rates are structured is a daily rate, but not to exceed amount. So obviously the needs of this long-term care population is varied, right? But what we did was increase our rates, and it's a daily not to exceed rate. So this is just a program that Clark County has had for many years, and all we did was kind of bump the rates up to aim to address the delays that we had in trying to obtain the care. So I don't know if that answers your question about negotiated rates. What we did is when we looked at what the providers needed, it was really clear we needed to add a medically complex rate and a behaviorally complex rate. It's based on like a ventilator. If we had a patient who was on a ventilator, based on the comparative rate for caring of a patient with those particular needs. And so we worked with them to determine an appropriate rate. Thank you.
Thank you for that answer. And then just to follow up, if we had a number of folks that were in the hospital for an extended period of time or in maybe a less appropriate setting for them because of their high support needs, have we been able to decrease the number of people that we have awaiting a more optimal situation? Is there a waiting list to get people out of the hospital?
I'm going to defer to my friend Bud Shaw at UMC. I think he can probably give you anecdotal evidence on that because this is, and just to be clear, the county's program, again, is for patients who do not have Medicaid coverage. So I know he can give you some data probably about the Medicaid wait time when we have Medicaid patients, but the county's program is really for people who don't have that pay source. But I'll defer to Mr. Shaw.
Thank you, and thank you for the question, Bud Shaw, for the record. The Medicaid, our patients who have been under and are under Medicaid, we have seen a really dramatic drop in the length of stay of our Medicaid patients, particularly those that require those higher needs that can go to a long-term acute care hospital. Those patients, because of the recent provider assessment fee that went into place the first part of this year, those facilities, along with other hospitals in the post-acute world, have had their Medicaid rates increased, and they're much more willing and able to accept patients out of our hospital into their levels of care. Hope that answers that question.
Thank you. I appreciate that. Thank you, Chair. I have one question for Washoe County. Thank you so much. Senator Ratty, thank you so much for being here in your presentation. I just have a clarifying question. Slide 10 identify the most significant areas of needs and gaps. And it starts out really looking like it's supporting folks specifically with mental health needs. But as we move down to the areas of significant needs and gaps, it looks like we're moving into multiple populations. And so I really want to know, are we talking about co-occurring disorders, or are we moving into other populations? And my example for you would be acute beds for children and adolescents, and then moving into housing for individuals with mental health and developmental disabilities. Are MH and DD, are you considering that co-occurring, or are we talking specific to mental health?
Thank you for the question, Julia Ratty from Washoe County. For the record, through the chair to you. So we are using the term broadly behavioral health, and so when we use the term broadly behavioral health, we are including all both mental health and substance use disorder populations, and then that specific bullet about IDD recognizes that if you are an individual with a developmental disability who also has either a behavioral health or a substance use disorder or both, that requires a whole special set of services to meet the need. So I think the answer for you is yes to all of the above.
Thank you for that clarification. Thank you, Chair.
Thank you so much. Let's go to Vice Chair Warnlicker.
Thank you, Chair. Thank you for the presentations. I have a question about the RCC. That this is a great program. I'm delighted to hear you have this recuperative care center that you're expanding, and I'm just curious about the how this, if there's a similar unit for the county, or you live in Las Vegas but not within the city limits, you're unhoused. Do you screen people based on their address, and how do you do that? Or do you just, anybody who is referred, you'll take in?
Thank you for the question. This is, for the record, Saber Newby. We take everyone. So as long as we have a bed, we don't discriminate based on where the person is coming from. When we look at our data, we see that we get patients from hospitals all over the valley and locations all over the valley. So we're equal opportunity.
Well, thank you for doing that.
Thank you. Any other questions? I think so I did have two questions. I think one of them, well, actually, I think there's several questions. Let's start with Senator Ratty up in Northern Nevada. You know, one of the things that there's been this theme, right, of what does accountability look like for each entity that is intertwined into the mental health delivery system. And I think I saw it in your presentation where there's discharges that are existing simply because of Medicaid rates, or because the hospitals don't want to hold on to them because it's very expensive care. And so what I have seen just firsthand is that there's obviously a level of accountability that has to come with each separate entity, right? Whether it's the hospital provider or the mental health facility or law enforcement. And so how do we have this conversation of what is appropriate versus not appropriate? And then what are the parameters to making sure that we're incentivizing either the hospital or law enforcement to do the work that's necessary? And I'll give a good example. I have a lot of friends that work in EMS, and many of the folks that they interact with are folks with mental health disorders who are homeless. And, you know, in the summer times, it's very common where, you know, they might interact with this individual. It's to the point where it's very common where they even know their names, right? And they pick them up and they ask them, you know, are you okay? It's hot outside. It's 120 degrees. Do you need anything? And they say, no, I'm fine. Actually, yeah, I do need to go to the hospital. And when they arrive at the hospital, it's not even a mental health concern. It's something as basic as I needed to charge my phone and it's hot outside. And so I think that there's obviously situations where EMS needs to be held to account to the same way that law enforcement needs to be held to account, to the same account that the hospital systems and so forth, right? And that we're not passing the buck. If we have a patient in front of us that needs a level of care, that we're providing them with the wraparound services so that we don't get to the point where Clark County Detention Center is the facility where they're receiving treatment. I think all of us can agree to that. So how do we reach that is probably my question of, maybe it's more of a philosophical question, but I think that would be helpful from your fair background.
Thank you for the question, I think, Chair. That's a relatively complex question. So Julia Ratty from Washoe County for the record. So I think what I would say is that we do need to remember that the overall system of care is complex and has many players, and that the bulk of the care that is provided by a mix of providers and payers in the for-profit or nonprofit realm, and then local government, whether that be our human services agencies or our law enforcement or our courts or all of the lists that I think my colleague from Clark County went over, are providing that safety net role. And so I think we have in local government built-in accountability, if you will, in that what we talked about a lot at the beginning of this presentation is that our own departments, divisions are having a challenge being successful in delivering to their core mission because of the challenges that come into their systems around behavioral health. And so wherever we can be innovative and we can be getting on the front end of some of those issues, and that means that then the overall court system or the overall child welfare system, for example, works better. There's sort of a built-in incentive and lever there. I think where the legislature probably needs to focus is more around the provider-payer side and what are the levers that you can push and or pull to incentivize the behavior that you're looking for. And I think Director Weeks from the Medicaid side of the equation gave some really good examples. I think, again, my colleague from Clark County, Joanna Jacob, talked about how you can use rates to incentivize the behavior that you're looking for. But it does end up being a combination of carrots, rates, and different incentives that you can provide to get the behavior that you're looking for. And on the flip side of that, mandates to make sure that the things that you want to happen are happening. My experience has been that mandates are less effective, that we put in mandates and that the system will find creative ways to meet the very minimum standard of that mandate, but maybe not the true spirit of that mandate. And so I do think a lot of it ends up being on what levers can you push in terms of incentives to get the behavior you're looking for. Was that responsive to your question, Chair?
Yeah, no, that's exactly it. I think you are correct. It's kind of it's a mix of all of the above, right? And I think what we need to figure out as a committee is how do we incentivize one lever while also ensuring that we're in compliance with what we're requesting for and that the dollars actually feed to providing delivery of care. I think it's exactly how you phrased it. So perhaps my next question is maybe for Saber in the city of Las Vegas. Some states have, and feel free for anyone if this is of interest, some states, from my understanding, have piloted mobile pharmacies. In your presentation, you talked about how a lot of the folks that you interact with from the city of Las Vegas often go from untreated diseases, whether it's uncontrolled diabetes or so forth. Is that of interest? Is that something that we should look at in this state so that maybe perhaps the city of Las Vegas can pilot such a program? Have you guys talked about that internally?
Thank you for the question, Chairman Doniate. For the record, Saber Newby. We haven't piloted mobile pharmacy per se, but we do have what we call our street medicine team who goes out and meets folks where they are and can be that sort of conduit between the streets and the pharmacy. If any of you have been to the courtyard, we have the street medicine team there at the courtyard. We also have a new clinic that we just opened up. And so that's sort of the conduit that we try and work on. We'd be intrigued about a street pharmacy. Not sure how that would work.
Okay, thank you so much. And then the last question was for our rural health folks, for Ms. Valerie Haskins, if you can step forward. One of the things that you mentioned, which was I thought was very interesting, and this is just my last question, and then we can go on to the next agenda item, was reference to. So I'm glad that you mentioned the policies that your board is tackling, especially with workforce. We won't use RBDR if you guys are already tackling that, so I think that's great. But the one that probably was most interesting to me was exploring regional behavioral health policy boards and exploration of behavioral health authorities. So talk to me about the difference or where the evolution of where you think we need to go towards.
For the record, Valerie Haskin, Rural Regional Behavioral Health Coordinator. With that, I believe my sister board, the Northern Regional Behavioral Health Policy Board, was going to attempt to tackle the regionalization of behavioral health last legislative session. However, there was still a little bit more research that needed to go into building that out. When I think about what this might look like, I would foresee keeping the behavioral health policy boards separate and maybe advising regional authorities and having these as separate kind of regional, I don't know if it would necessarily be state or local districts of some sort, more similar to like a public health district, I would foresee in building these out. And having that behavioral health authority then having the ability to carry some of these grants and also not only work directly with the local jurisdictions, but also helping to provide some of that oversight that has come up in conversation regarding what's going on with quality. Are we making sure that everyone's doing what they're supposed to be doing? Which, when we're looking at rural Nevada specifically, is a major concern of my counterparts and I, is ensuring that nobody's going out to rural Nevada to maybe not provide the best services because they don't think anybody's watching.
I think that's helpful because my first instinct of a question would be, would it be comprised, I mean, is it going to be competing with the health districts if there's health districts already there? Is it comprised of elected officials, law enforcement, EMS representatives, emergency management, right? Like, I think those are the things that I'm definitely interested in. I think, to me, regionalization makes sense because you're focused more on the community itself, and the rules respond differently than Clark County does and Northern Nevada does. And so, but there's obviously a need of centralization too, where the state has to have some level of accountability to oversee the entire delivery of care. So I think that was very interesting. So I would be eager to learn more, and maybe we can talk offline of what that could look like. And obviously, with power comes funding. So all of the above. Yeah.
Thank you.
Great. I don't think we have any other questions. I think we'll go ahead and conclude this agenda item, and we'll move on to the next one. So I thank our officials, of course, for joining us. We're going to go on and move on to agenda item 10, which is an update on the establishment of the Behavioral Health Workforce Development Center for Nevada, pursuant to AB 37. And with us, we have Dr. Sarah Hunt, who's the Executive Director of Be Here Nevada. So please proceed when you're ready.
All right. Good afternoon. Thank you, Chair Danyate and members of the committee, for this opportunity to come before you today and share a little update on Assembly Bill 37 and how we have been working to implement it. Before I get started, I do just want to take a personal moment of privilege to acknowledge the partners that helped us get this far. Certainly the Rural Regional Behavioral Health Policy Board. They were the sponsors of Assembly Bill 37. Implementation is now under the direction of the Nevada System of Higher Education through the Board of Regents. Our administrative hub for Be Here Nevada lives in the Kirk Kerkorian School of Medicine at UNLV, and we are partnering with the UNR Office of Statewide Initiatives on a lot of our data collection. So just a few slides to quickly remind you of what Assembly Bill 37 does. It authorizes the establishment of the Behavioral Health Workforce Development Center of Nevada under the Nevada System of Higher Education. And a reminder that this is really a grow our own pipeline project. So starting with initiatives and outreach in the K through 12 system to plant those seeds of career options in mental and behavioral health, and then working with those students, other individuals along the way to move them into higher education pathways, leading to professional licensure or practice, and retention of the existing workforce. So another way to show that is the summary of Assembly Bill 37 requires us to go out and provide more outreach and education about behavioral health professions in K through 12, but also to potential adult learners, so those individuals who may be working in other professions or entry-level health positions that would have an interest in coming back in to kind of upscale their career skills and connect them to the education pathways in NSHE. Looking at our behavioral health programs that we have at the higher education level, is there opportunities to create new degree programs, expand the ones that we have, make sure we have strong connections within the NSHE system. So students who want to transfer between institutions, there's the accessibility to do that, and that retention of the existing workforce, but also looking at how we can better bridge from our students graduating to then supervision and licensure by one of our licensing boards. One of the things that the rural board also wanted to see in this initiative is some form of a business technical assistance program. So for those individuals who may be coming into the state of Nevada to do business in the area of mental and behavioral health, they would have a place to go to answer questions like, how do you get a business license? Who are all the different licensing boards that we have for mental health professions, that type of thing. A reminder that the infrastructure for the Behavioral Health Education Center is to have an administrative hub at one of the institutions within NSHE with spokes out to the other NSHE institutions across the state. So how have we been implementing this? So after the bill was passed in the last legislative session, what needed to happen next was that the Board of Regents needed to designate that administrative hub. That was done at their September 2023 Board of Regents meeting. UNLV had submitted an application to become that hub, and that was awarded in September. So effectively, Be Here started in October 1st of 2023. And Be Here is the name for the Behavioral Health Workforce Development Center. It's an acronym for the Behavioral Health Education, Retention, and Expansion Network of Nevada, which is a mouthful, but shortens really nicely to Be Here Nevada. Since then, I just wanted to note that you had also heard a presentation earlier in one of your previous meetings about the Silver State Health Improvement Plan. We are part of that health plan. So we officially are Goal 2, Objective 2.1, to establish the Behavioral Health Workforce Development Center of Nevada. So what have we been doing really the past few months? Since January to now, a lot of the time has been spent on filling positions. So to do the lift of creating our workforce pipeline, it takes multiple people. I cannot do that myself as the executive director, which I'm just realizing I did not introduce myself. Sarah Hunt, executive director for Be Here Nevada, so sorry. So at this time we have 5 full-time staff now, 1 graduate assistant, and I wanted to note that our staff live in northern and southern Nevada. We have been working on developing our outreach and marketing, so having a social media presence, but having a website. So as we're going out and doing all of this education and outreach, we needed to have a place to draw people to get more information. We've also started issuing a monthly newsletter. We've been doing things like this, providing follow-up presentations and attending meetings with our stakeholders to give them an update on, so the bill passed, what are you doing? And along the way, we've been doing a bit of a listening tour, is what we're calling it, on our staff. So we've had meetings with all of our sister NSHE institutions to really meet with all of the mental health training programs at all of those different institutions, but also to meet with the staff of the pre-college programs that live in all of those institutions to understand what are the connections we already have between NSHE and the local K through 12 systems. I just wanted to drill down a little bit more about what we're doing through the K through 12 outreach, because that's where we've really launched our efforts so far. So I know that says 5 high school career fairs, sorry, that should be 4. So we have attended high school career fairs at Fernley High School, Yerington High School, Dayton, and Silver Stage High School. To date, we have probably provided outreach to over 200 students about what it means to work in mental and behavioral health, what are the different options to do that, what are the different career education pathways to pursue those opportunities. Our staff was also able to be a part of the Pre-Professional Health Summit through High Sierra AHEC recently. And just this week, our staff were involved in workshops with continued outreach to high schoolers through the UNR Upward Bound office and the High School Health and Human Services Career and Technical Education programs. That is just a slide with some action shots of Be Here being rolled out. So that is a picture of one of our first high school career fairs. We had a table at Fernley High School. That was a picture of our road trip out to Great Basin campus in Winnemucca. And then I wanted to just show one of our example of our social media posts. So March was Social Work Month. So in our post, we made sure to link to all of our NSHE social work training programs. What's next? So we are working on that continued outreach to K through 12 to find the best doors that we can step into to, again, whether it's high school career fairs, workshops. We've had a lot of conversations with the Career and Technical Education program, continuing to collaborate with the NSHE mental and behavioral health training programs to make sure they know who we are, but also working on now connecting how we can best connect our graduates to, again, licensure and employment in the state. Data, data, data. So that's one of our next big projects. We're hoping to bring on a designated data analyst to help us start to really track the mental and behavioral health workforce numbers. That's that agreement we will have with UNR Office of Statewide Initiatives. We've already been exploring grant opportunities, and we're patiently waiting for the moment that we can announce, hopefully, a grant that we've received a notice of intent to award, but not able to fully announce that yet. And our first legislative report to all of you is due at the end of June. What we want to focus on in the next fiscal year, certainly we've been doing a lot of seed sowing in K through 12. We also want to start balancing out that with focusing on retention and where we can start doing some outreach initiatives to that. The bill also asked us to convene an advisory consortium to help us work on a strategic plan, and we will be working on that in the next fiscal year. I mentioned that business technical assistance, so we're going to look at the best way to create that and get that going, and continued funding. So we are funded through a fiscal note that the Nevada System of Higher Education has submitted, and we're working with them to be included in their budget request going forward. Some opportunities, just what we've picked up so far along the way. There are really a lot of great opportunities that are presenting themselves to expand just career awareness about mental and behavioral health at all levels of education, certainly in K through 12. The students that we've talked to at the high school career fairs that already have an interest in going into mental and behavioral health, we're learning that starts with taking a psych class. So they've either had an AP psychology course or some other CTE-related psychology course, and that's how they're learning about it. So, but we're also, when we talk to our associate degree programs at the higher ed level, there's an awareness of needing to plant the seeds with those students finishing their first 2 years of higher ed about the importance of thinking of graduate school if you want to go into mental and behavioral health and do that traditional therapy work. The acknowledgement of social determinants of education. So how can we even get those students that we're talking to in K through 12, those potential adult learners, an awareness of what they need to have to feel best supported to come back into higher education. And that kind of leads into the next point, scholarships. So while the state has done a lot of things, even in the last session, to expand student loan repayment programs, and that's often what people bring up when we talk about workforce development, there is really a need to be able to fund students coming into higher education to begin with. Growing higher education training programs, there's a lot of discussions right now within the Nevada System of Higher Education about, do we need to establish new degree programs that could help fill in the workforce shortages? If we needed to expand the number of students we can take in our already existing academic programs, that would require more faculty, and that would require probably an ask of all of you. And that data collection. As we're kind of starting to meet with the licensing boards, we're getting a better understanding of what we actually collect when our clinicians are renewing their license or they are applying for licensure for the first time. Some policy considerations, just as my last slide here. So I was at a recent presentation at UNLV from a psychology doctoral student who was presenting her dissertation research looking at school absenteeism in kids in the foster system. One of her, kind of conclusions was that certainly there's a shortage of providing behavioral health care. And she, as a doctoral student in our psychology program, said we are currently training psychology students to leave our state. What that means is when you are finishing your doctoral program in psychology to become a psychologist, there's 1 year before you graduate that you have to go do an internship, kind of like a residency a bit. We don't have currently any accredited placements for students who are interested in child psychology to do that training within our state. So that led me to, I just wanted to remind you of a few bills that were brought up in the last session that did not pass. Senate Bill 300 was brought by Senator Heidi Severs-Gansert, and that would have asked for an appropriation to fund those specific type of placements, those pre-doctoral internship placements, as well as a postdoctoral fellowship placements to retain our psychology students. Expand reimbursement for services provided by psychology trainees. So currently Medicaid, if you are training a doctoral student in psychology, they're doing a practicum placement, you accept Medicaid, you can bill for their services, but beyond Medicaid, you cannot do that. And Assembly Bill 69 was from the Washoe Regional Behavioral Health Policy Board. It, again, was looking at student loan repayment, but with a very focused lens on expanding the state student loan repayment program options for behavioral health providers. That included behavioral health providers that work in traditional settings, but also in the K-12 system, those school-based mental health providers. And it would have offered student loan repayment program for faculty who teach in our mental health training programs. And sometimes that would be a very good selling point to help recruit individuals into our open faculty lines. So I'll end with that. I think you all see a picture of a really cute stuffed elephant at the bottom there, excuse me. That is our mascot, Winnie, and her name is from Winnemucca, where I first went to meet with the Rural Regional Behavioral Health Policy Board to talk about creating a behavioral health workforce center, and here we are. So also I'm told if you take a picture of the QR code, you will then be able to sign up for our groundbreaking newsletter with hot off the presses information. So happy to answer any questions.
Thank you so much. Committee members, any questions? Assemblywoman Brown-May.
Thank you, Chair. Thank you for the presentation in closing with Winnie, the elephant in Winnemucca. I have a Winnie's counterpart in my office because I was told that you should never be afraid to address the elephant in the room. So you talked a lot about launching into outreach and developing professionals that are going to support behavioral health. I'm curious to know, are we working at all to develop a pipeline for non-traditional students that might not ever see themselves with that professional credentialing, right? How are we getting the boots on the ground, people that are providing services now, right? Whether it's an applied behavioral analyst, a registered behavioral technician, just a technician, right? Somebody in an entry-level position to develop them in the professional field. Can you speak to that a bit?
Yes, thank you for the question, Sarah Hunt, for the record. Yes, so that will be part of our retention efforts, recruitment efforts, actually. So yes, in the next fiscal year, we're going to be developing some specific outreach to those individuals that are, we call them potential adult learners, non-traditional students, those individuals that are out there working, maybe already have some experience working in mental health or healthcare in general and have an interest in coming back in, but they're not sure what their options are. So we would be planning that targeted outreach to them.
Thank you, I appreciate that. And then secondarily, building partnerships with the potential employers, right? How are we able to take people that are employed in whatever that facility or location is currently and developing those individuals into professional fields while they're working on the job?
Again, Sarah Hunt for the record, thank you for the question. So that really speaks to those social determinants of education. So what do you have to have in place if you're already a working adult to come back in into higher education? And so those are the things that we want to look at and things that we want to talk with when we start to do our listening tour with the employers. We think about those community health workers. We heard a lot about peer support specialists. Those are definitely groups that we want to talk to, but with the understanding that there is a need to be able to continue to support yourself and your families if you've already been out there working and are thinking about coming back into higher ed. So we want to have those conversations and see where that leads us with figuring out that might lead into some policy suggestions. So to be continued on that.
Thank you. That's great clarification. I'll just throw out there, there's a pool of people that are currently working as personal care attendants, right, PCAs, that may naturally fit into this as a career field, or direct support professionals that are serving our folks with developmental disabilities. Again, the likelihood that they would move professionally, given the right mechanisms, would be greater.
Sarah Hunt for the record, thank you for that recommendation. We will add them to our future meetings list.
Great, thank you so much. I don't think we have any other questions, so we'll go ahead and close out this agenda item, and we thank you for coming. Okay, we are now at the last agenda item. I'm going to combine two agenda items. I think we have agenda item 11, presentation on state policy options to address the behavioral healthcare services. That's by NCSL. And then we have two that were submitted to us, one of them from the Hospital Association and the second one from Mr. Musgrove. So we're going to start with NCSL. Hopefully they can present around 5 minutes just on the broad policy recommendations that other states have implemented, and then we'll go to the Hospital Association and then Mr. Musgrove. So again, the point of this is just a brief overview of the policy recommendation, and then if the committee members have any thoughts, recommendations, or questions, that we would take them on after. So Mr. Roman, if you're ready, please proceed.
Can you all see my screen okay?
Please proceed.
Awesome. So thank you, Chair Donate and members of the committee for inviting me to speak today. My name is Sarah Jeroman, and I'm a policy associate with NCSL. My portfolio includes all things health technology as well as healthcare facilities. And I was invited today to share more about state legislative trends related to cross-state licensing in telehealth. And so as you stated, for the sake of time, I will be skipping around quite a bit to get right into occupational licensing and the facilitation of telehealth across state lines before finishing up with some additional resources and then taking any questions that you may have. And just as a very quick reminder, NCSL is your membership organization, and we offer all of the services listed on this slide to our members, legislators, and legislative staffers. And before jumping into content, I have to note that NCSL is a bipartisan organization, and NCSL staff are nonpartisan. And we do not advocate for or against any state policies, and any policy options that I will present today are solely for informational purposes and do not indicate NCSL support. And as I said, I'm going to skip ahead a little bit right here to licensure by endorsement or reciprocity. Traditional licensure processes may deter out-of-state providers from practicing on in-state patients via telehealth due to their often expensive and lengthy nature. Endorsement and reciprocity licensure processes may remove some of these barriers and make it easier for providers licensed in another jurisdiction to practice on patients located within another state. These options are typically not as comprehensive as universal licensure provisions, and states will often direct their departments of occupational licensing or specific licensing boards to develop by rule their own endorsement procedures. Generally, application processes allow the licensing boards to check an applicant's credentials and their education in whichever state that they are already licensed in. This may be a useful option for states when another state is not a member of a compact or within a reciprocity agreement. And I've included a few examples of states with licensure by endorsement or reciprocity on this slide. I won't go through all of the state examples in this presentation today, but I have included summaries as well as links if you want to explore any of the examples further. And with that, I'm going to skip past interstate compacts completely, but let's talk about special registration or licensure. So some states will allow out-of-state providers to practice telehealth in their states through telehealth registries or special telehealth licenses. Licensed out-of-state providers may provide telehealth services after completing the registration or licensure requirements. States have some variation in how they oversee telehealth registration or special licensure, but typically providers must meet the following terms. They must possess a current, valid, and unrestricted license in another state. They must not have been subject to any past disciplinary proceedings. They must maintain and provide evidence of professional liability insurance. They should agree not to open an office or offer in-person treatment within the state, and they must annually register and pay a fee with the appropriate state licensing board. The following map shows in green the states that have had an active telehealth registry or offered a special license for providing in-state telehealth services as of September 2023. This includes 13 states and the Virgin Islands. And on this next slide, I've included some of these specific state examples. Again, this slide includes 3 state examples that you can dive into further via the links. But I do want to note that Vermont in particular created both a special telehealth license and a registry with the House bill that is listed, and the rest are one or the other. And on this slide, there's some more in-depth information about a few state registries. In particular, registries are often a simpler application process than full or even special licensure, and it diminishes the burden for many providers, though it does not remove it completely like some of the other alternatives that I'll discuss in a moment. And again, I won't dive into these examples, but there are here with a little more information if they are of interest. And the last bucket of state options that I will talk about today is exceptions to in-state licensure requirements. So some states have created specific exceptions to in-state requirements that will allow out-of-state providers to practice telehealth if certain conditions are met. In some cases, some states have created both special licensure or registration and certain exceptions to in-state requirements. The data that was used to build this map comes from the Federation of State Medical Boards, and as you can see on the map, 13 states in DC in green will allow episodic, or in other words, irregular or infrequent care visits or follow-up care exceptions to licensure. 24 states in Guam in gold, including Nevada, will allow consultations only. 5 states in the US Virgin Islands listed in purple will allow other exceptions, such as Colorado, who has limited exceptions for certain out-of-state mental health care providers who provide care that is within their scope of practice for less than 20 days to someone in the state of Colorado. They must also disclose their lack of in-state licensure to that patient. And 8 states in Puerto Rico do not have any exceptions currently to licensure. Again, here are some of these examples on this slide, specifically of Nevada's neighboring states, Idaho and Oregon. And then as I wrap up my presentation, I just want to share a few other related trends that we are seeing. I know someone covered reimbursement, so I won't even touch on this slide at all. But then in addition to reimbursement, there are a few other types of state regulation that may impact telehealth care by out-of-state providers. First, we have teleprescribing, or the ability for a provider to initiate a prescription after a telehealth visit. After some of the flexibilities that expired in the pandemic, a lot of states are clarifying or defining how and when providers can prescribe via telehealth. Because I haven't included the summaries on the screen, I will just note that Pennsylvania example relates to psychologists' ability to prescribe, including allowing them to issue prescriptions via telehealth. And Vermont allowed authorized providers to prescribe controlled substances for the treatment of opioid use disorder via telehealth. And then next we have facility fees. And so facility fees were historically associated with hospitals or other emergency services, but they've become increasingly common in non-hospital settings, and they've increased in both amount and frequency in recent years. And so as such, a lot of states are exploring legislation to protect consumers from unknown or costly facility fees. And so some of these bills, including Connecticut and Ohio, prohibit facility fees for telehealth visits because of the high cost associated with facility fees could disincentivize patients from utilizing this care option. And then I've also included a few examples related to broadband access, particularly in rural communities. I know a presenter earlier talked about how that's a really important step in ensuring patients in these types of communities are actually able to access telehealth care. And then lastly, one miscellaneous bill from Pennsylvania related to funding for telehealth for behavioral health providers specifically. And just the last part of this presentation, I've included various resources related to bill options. And so these next two slides contain a variety of pending or enacted bills from this legislative session that relate to telehealth practice across state lines, with links for your further exploration of the bill language. And here is a comprehensive list of all of NCSL's relevant telehealth and occupational licensing resources. And this is my contact information in case it's of use to all of you. And thank you again, Chair Doniate and committee members, for your time today. It was an honor to be here, and now I can take any questions.
Thank you so much. Any questions from committee members? I don't think we have any, so thank you so much for joining virtually, and I'm sure if we have any follow-up questions, we'll be sure to share them with you. Let's go ahead and invite Mr. Pat Kelly to the dais. Welcome back to HHS. Whenever you're ready to present your proposal, please begin.
Good afternoon. My name is Patrick Kelly. I'm with the Nevada Hospital Association. We submitted a document of about 11 pages, very detailed. I would say that probably today we covered about 80% of the items that are in there, so I'm not going to go over this. I wrote a really beautiful testimony that I'm not going to use now, but just trust me, it was great. So I want to talk about, the big theme that we heard today was the continuum of care. And we do not have a continuum of care in behavioral health. And that's one of the big problems. We talked about the missing of the middle, which I thought was a great term. But in some areas of the state, we're also missing the beginning and the end. So please keep that in mind. We talked about crisis stabilization centers. And I want to point out to you that there is a crisis stabilization center that's currently operating. It's the Mallory Center at Carson Tahoe Hospital. And so they have only been licensed for a few months, but they have been operating as a crisis stabilization center for a while. And the big problem they're experiencing is the reimbursement. They don't think that they're going to be able to just break even with respect to operating the crisis stabilization center. And I know that other providers, that's their biggest fear, is that they don't think that the current rate is going to work. And what has been suggested is that they separate out the physician component from the per diem care component, that's the physician is going to be the big issue. They also talk about the fact that they don't have access to 24-hour services. Once they have these patients, they can't send them on to someone else. So this kind of exemplifies the problem. So Carson Tahoe originally put this center in to divert people from the emergency room, but they're always full. So it's not working anymore. They are taking care of folks in the community, but it is not diverting enough patients from the emergency room. So that's a big problem. And that's what the other providers are seeing and are worried about. And that's why this has been so slow to take off. So I want to mention something about the uninsured too. That is a problem for crisis stabilization centers. So they have people come in who are uninsured, can't qualify for Medicaid, and they have to provide free care to them. Well, that gets expensive, and if you get a lot of those folks, that becomes an issue too. And that's another reason why we really need to have the Medicaid rate higher to be able to cover a lot of those uncompensated folks that come in. Just want to talk about the state hospitals for a second. So we talked about the fact that a lot of the beds are being converted to forensic beds. And so every time they convert a bed to forensic, that means we lose a civil bed. And we're also having a problem in some areas where they can't afford to staff all the beds they have. So we're really getting backed up in that area. So really need to look at figuring out how to help them financially in terms of staffing and physicians, and also how are we going to create more civil beds? Because what's going to always happen here is a court is always going to order something saying we need more forensic beds. But there's nobody on the other side ordering that we have more civil beds. So it's going to end up, it's going to be all forensic beds. I'm concerned. So I want to share one thing with you. I've talked to the psychiatric hospitals, and one thing they want you to know is that the issue isn't that we don't have enough beds. The problem is they can't afford to staff all the beds. So at any given time, we have a considerable number of psychiatric hospital beds that are open, but they can't afford to staff them. So I do think that the Medicaid provider fee program is going to help with this eventually. But one of the things they talk about is that we should be reimbursing behavioral health patients based on their acuity. Because what happens is if you have a patient comes in and you have to watch them 24 hours a day, that just eats up the per diem. There's nothing left pretty much after that. So, you know, if we have a high acuity patient, they really should be reimbursed at a higher rate for that, because it does take a lot more services to provide that. And that's kind of what we talked about with targeting incentives. I mean, they take them now, but they're incredibly expensive. Managed Medicaid. Now, nobody's talked about this. So what's happened is that the MCOs get the contract for the whole area. Right now it's Washoe and Clark counties. But often they subcontract the behavioral health portion out to another entity. And what's occurring is that the same entities are naming themselves differently, and they have the same ownership and everything, and they're picking up the contract. So it looks like we have different providers, different MCOs handling behavioral health, but in reality, it's pretty much the same people who are doing it. And this creates an incredible amount of control and inability to negotiate rates, and that's going to become a big problem. So I'm just kind of alerting you to that coming up. The state should ensure also that there's an adequate network, that they're actively accepting patients. So they'll put somebody on their network and say, you know, we've got this person under contract, but they're not accepting any patients. Well, that doesn't do you any good. I mean, so that needs to be looked at too. And that the time frame should be resolved for provider disputes with claims and denials. You know, we've talked a lot today about getting the providers the higher reimbursement. Well, if you're getting payments denied and claims denied all the time, it's just eating away at that. I mean, so that has to be watched, because if not, the money is not going to go to the providers. It's going to end up going into the pockets of the MCOs, and that's not going to help. Now, the behavioral or the rural hospitals and providers don't have this problem now, but starting January 1st, 2026, they are going to have this problem because we go statewide with Medicaid. So that's going to be an issue that's going to develop. So let me just say, just want to mention housing. You know, years ago, we went through a process in America where we deinstitutionalized mental health services. We didn't have those big hospitals, the one flew over the cuckoo's nest type thing, and that was a real positive. But one of the problems is that there were no facilities for these people to go to, and that's partially what occurs with the homeless. And we have people who we see regularly coming into hospitals who just don't take their medications. And so I would wonder if there's a possibility to create a housing situation where there's at least someone to kind of supervise people to make sure they are taking their medications and doing other things, not hospitalizing, not restricting their ability to go out in the community, but just being there as additional support. So I just want to throw one more thing out before I leave, and that is, if you're really looking for an innovative idea and where to go, I suggest that you watch a 60 Minutes episode. And it was called Master of the Mind. And it was 60 Minutes usually does, 20-minute segments. They did 40 minutes because this is so groundbreaking. There's a place that has developed treatment using ultrasound to remove the cravings of addicts. And so what they do is they put you in a machine, they scan you, and they identify what area of your brain's triggered by drugs. And then once they identify that, they kind of zap it with an ultrasound. And so far, the results have been really fantastic. So my thought is, gosh, if we're looking for something to be on the forefront of, we should be following that and seeing where that's going to develop and seeing if we could bring it here, because not only would it help the individuals, but the amount you would save on incarceration and all these other services that we're talking about would be fantastic. And just imagine those young ladies who have been made addicted to drugs by their handlers and sex trafficking. If when they're out of that situation, to be able to be eliminated from that one burden as they're recovering would be fantastic. And that's why I think Nevada would be a really interesting place to develop that. That's all. Thank you.
Thank you so much. And that was a really good episode of 60 Minutes. I would encourage folks to watch it if they can. It's about 40 minutes long, but
Yeah,
it's
the
pretty
last
good.
10 minutes, it's the substance abuse part.
Yeah. Great. Thank you. Any questions from any of the committee members? It's a very extensive document. I would encourage all of you to read through it. Mr. Kelly and his team really went through it. I think I submitted this request probably back in December, probably. It's been several.
Earlier than that, yeah.
And you guys went through the process of really digging through of, okay, like what actually are the problems from all segments of the system. And so this has been probably one of the most comprehensive ones that we received so far. So I thank you for that. Any recommendations or anything before we move on? Senator Nguyen.
Thank you. It was a good presentation, short to the point, and the document is more thorough. And you can always submit those written words that you had so eloquently prepared to the committee if you'd like. I do have a question on if there are ways to, I guess, quantify the savings that there would be if we had increases to Medicaid reimbursement rates that would help improve this system for psychiatric hospitals or other providers when compared with the cost savings of the current model, which is where people just come into the ER, because that's not cheap.
No, I mean, you're looking at, probably a couple thousand just bringing someone into the ER and going through that process. And then if we have to ship them or transport them to a behavioral health facility, you got the transport cost. And then you start the whole cost with the behavioral health hospital going through. So it does become very expensive. And, there was talk about how many people were getting backed up in the hospitals. I mean, that's a huge number. I mean, we've been at times 400 or 500 people in our hospitals who are medically cleared for discharge, but we can't move them out. And I was glad to hear Bud Shaw talk about the fact that that's improving now. But it is a big issue. And not only is it from a cost standpoint, but the problem is when people are sitting in a hospital, they're not getting the services they need, because post-acute care facilities are designed for a purpose, and that is to get them up, moving them around, socialization, all those other things, that if they're sitting in a hospital bed for weeks, that's just deteriorating their recovery and is going to be a harder problem going forward.
Great. Thank you so much. I don't think we have any other questions, and if we do, we'll take them offline, but we
Okay,
appreciate
thank you all
joining.
very much.
Let's go to our last agenda item, or our last presentation from this agenda item, Mr. Musgrove, who has a recommendation on the hospice moratorium white paper, so please proceed when you're ready.
Well, thank you, Mr. Chair. Dan Musgrove representing Nathan Adelson Hospice today. And if I can take a moment of privilege just to thank this committee and the chair for all of the work that you are committing to behavioral health. It is refreshing, it is sorely needed, and thank you for the time invested today. I would offer to you that what I'm bringing up today in terms of what's happening in hospice right now, especially here in Clark County, is the potential to cause trauma as well for the families and those that are facing the end of life. We are seeing right now a proliferation of in-home hospice care that rivals only a few other states in the nation. And it simply is, we're seeing because of California about a couple of years ago got ahead of this. Their inspector general saw this ripe abuse that was taking place in especially Medicare hospice care, and they institute a moratorium. So we're coming to you today because we have seen those operators come to Nevada, Texas, and Arizona, and Nevada is now second to only California when it comes to the number of hospice care providers per 100,000. And I'm not sure that's a list we want to be number one or number two in, because we are seeing folks being taken advantage of because they don't realize what is what they are supposed to get when it comes to hospice or palliative care, what is required under Medicare. And so these folks that are dealing with end of life, whether it's the family or the individual themselves, are not getting the care that they rightfully should have. And here's a perfect example, and so much of what we're talking about is in the white paper that we presented. But Nathan Adelson, one of only 2 nonprofits in the state, the only one in Clark County, used to only see maybe 5 transfers a year from other hospices. Now we're seeing between 2 to 4 a week from sometimes hospices, in-home hospice providers that we've never even heard of because of inadequate care. So we're asking the legislature and the governor to institute this moratorium. Now, granted, it's something that the governor can do, obviously, when you're out of session, but we would ask that this committee think about providing a letter of support for that request. And also, the reason we would ask for this hospice moratorium is that we would want the legislature then to look at in 25 instituting more substantial requirements of those hospice providers to ensure that our loved ones, our constituents, ourselves aren't being taken advantage of these in-home hospice providers. Such things as mandatory reporting of the quality scores, allowing for no delinquencies. The state should confirm 1 hospice business license per address. As an example, there's an address on Lake Mead that has 11 hospice providers listed at that 1 single suite number. Multiple vendors operating 1 suite. If you go there, you knock on the door, there's a security guard there who gives you a phone number of who to call if you're having a problem. A survey of new hospice programs receiving Medicare enrollment at the 12-month, 18-month, and 24-month periods to ensure that they're providing the care. Proof that all 4 levels of hospice care are being offered in this 2-year survey. And what we mean by those 4 things, it's routine home care, general inpatient care, symptom management, continuous care in the home for symptom management, and respite care. At a minimum, that's the 4 things that any in-home hospice provider should be providing. I want this to be on the record that this is in no way a reflection on what our state is currently doing when it comes to trying to investigate these claims. You know, the trouble is that these are Medicare, not Medicaid, so it really is a CMS responsibility, but we need to get ahead of it. Because obviously CMS is well aware of it. They've sent inspectors to investigate, but they have done nothing yet. And I would hate to see Nevada not recognize that we have a problem and take action if we can. So again, we are just asking for your support and open for any questions.
Thank you so much, Mr. Musgrove. No, I think you're spot on where, I mean, I've had conversations with our federal delegation where there are instances of fraud and abuse that could exist in our healthcare system that are happening in our state borders, but because of the federal delegation, not delegation, but the delegation of powers, that sometimes it does fall into CMS, but I mean, CMS is so large that maybe they're not able to do it. So what is the role of the state government to at least make sure that the consumers that are here are protected, even if they are Medicare patients? Because at the end of the day, it's still our responsibility to ensure that care is delivered. And hospice care is not the only place where this is happening. This is also happening, I've alluded this before, but also in home health care, where we're seeing different entities pop up. And I think we kind of heard that from an earlier presentation where there's, in behavioral health, there's signs of fraud and abuse, of course. And so ultimately what is most important is making sure that the providers that exist in this state live up to the expectations and that there's some requirements of who are starting these businesses, and it's not just Joe Schmo that wants to run a healthcare facility. There has to be some training or requirements of, are you competent to deliver the care that you are going to be entrusted to do if you seek reimbursement, right? I think that has probably been the most important thing, but I don't know if any committee members have any questions, or Vice Chair Licker.
Thank you, Chair, and thank you for bringing this problem to our attention. So I think you're absolutely right. We need to prevent these abusive programs from starting. I'm just wondering about if this is the right policy, because it doesn't address the ones who are already here, and it prevents good ones from coming in. Is there a way to target our policy at the bad ones, both that might come and that are already here?
Mr. Chair, Dan Musgrove for the record. I think you've hit it on the head, Vice Chair Licker. we certainly want good operators in the state. And this isn't certainly an issue of competition for Nathan Adelson Hospice. And that was a conversation that I had with Senator Titus about her concerns, because there is certainly not enough of these type of providers in the rurals. But you know, we're asking for, I think we have enough in Clark County at the present time. I think that this pause gives the legislature the opportunity to do exactly what you're talking about, is look at what can we do, whether it's through regulation or statute, to make sure that the state has the tools that it needs to make sure that these operators that want to come to Nevada are the most appropriate, are willing to do what's necessary to take care of our constituents. I don't think we're there yet. I don't think, you know, when we talk to HCQC within the Department of Public and Behavioral Health, they're very aware of it, but they're complaint driven. They really can't be proactive because there isn't enough tooth in the law, so they have to react to complaints. And very candidly, it's tough for us to get a family that is in this position to really be willing to go through the complaint process, because they've just lost a loved one, they're still grieving, or they're just done with it. They didn't realize that they were being taken advantage of, and it's past now. Their loved one has passed away, and it's hard for them to be willing to make that complaint, because everyone that we've offered up to HCQC, they've looked at and they've taken action, but it's not enough. So we're just asking for some kind of proactive solution. I think you've hit it on the head. What can we do? We think the legislature should probably take it up, at least until CMS takes that action.
No, I greatly appreciate that. You know, I think it's a classic example of, you know, there's plenty of stories, not just in this state, nationally, of folks that go into healthcare thinking that they're going to make money. Specifically, sometimes there's Wall Street entrepreneurs that say, you know, I'm going to go and build this, or try to build the next ecosystem or venture in healthcare, and then they realize it's not as easy as they make it seem. But then oftentimes there needs to be some level of compliance of, do you have the expertise to even run these facilities, or what you've been entrusted to deliver on? And I think that it's not really an effort of competition. It's more so, do we have the quality metrics in place? And I think that was kind of what we were talking about earlier this morning. It's not just, okay, let me just submit the CPT code to get reimbursed for it and call it a day. Like, there has to be some accountability of what we're delivering upon. So I appreciate the recommendation. I'm sure we'll have a chance to review it. If there's any revisions, please feel free to mention it to us, but we greatly appreciate your time. That concludes this agenda item. We are now toward the last one, which is public comment. So I'm going to go ahead and open public comment. It's limited, again, to 2 minutes each. So if there's anyone in Vegas that would like to provide public comment, please come forward. And of course, to remember to state your name. I don't know if we have anyone in Carson City, but if folks are, I don't think we have anyone there. So please begin.
Giuseppe Mandel, Desert Hope and American Addiction Centers Treatment Center. I just want to thank every one of you and all the presentations. I think I learned more today than I probably would have in 6 months of college. So I really appreciate it. Pat Kelly, he answered just about everything I had written down during the whole presentation, so that was phenomenal. And I do encourage each and every one of you, not to plug our own thing, but we're in the private sector of the drug and alcohol treatment. We do service a small portion of Medicaid, and we do what we can to help, but we are a for-profit business. I do encourage each and every one of you, and any one of us behind us, to come down and take a tour. Just get with me. I'll show you, give you guys a tour, and we can show you how the private industry does it. We've been very successful for years, and maybe you could build a model off of that, and never know, be able to help some of your loved ones or friends or family. I lost a brother to fentanyl 3 years ago. My daughter's the face of the fentanyl ad campaign out here for Risk It All with fentanyl. So, I mean, I'm entrenched in the community, and I know what it's like to have a loved one or family member that needs treatment as well. So if any one of you would love to come take a tour, please let me know. I'll give you a tour of our facility, and all our information is free of charge to you. It's whatever helps the state. We're more than happy to be transparent with.
Thank you so much, and thank you so much for your advocacy. Anyone else in Las Vegas?
Thank you.
I don't see anyone in Carson City. BPS, is there anyone virtually?
Chair, your public line is open and working, but you have no callers at this time.
Thank you so much. I'll go ahead and close public comment. As I mentioned, the next meeting is focused on children's mental health, so I look forward to seeing everyone, and thank you so much to our committee members for participating in this long but hopefully inspiring meeting. So meeting's adjourned.
Thank you, Senator Doniati.